you, all my friends from here, from the United States, from everywhere. I'm so happy to be here. It's a small format, something different. It's always a bit difficult to do something different, but personally, I learned a lot from first my patient. When you take care of your patient, they teach a lot. And second, I learn a lot from discussion. And most of the time when you go to a meeting, you learn, of course, but not that much for me. But discussion, especially from clinical case and the patient, are for me the two ways to continue to improve myself. So, a French American invention. I put French in top. So why? Of course we know that everybody knows this slide. The idea to invert the two positions in the shoulder arthroplasty, it has been developed in Germany, in England, in the United States. Probably the most important one was in the United States in the early 70s. It had been developed by Neer. So the first real reverse shoulder arthroplasty has been done in the United States. But if you look at this, of course, you will see a lot of things about the Mark 1, Mark 2, Mark 3. But I want you to focus on this. Because if you are old, like me, at this period, we used to do exactly the same than for the hip. Meaning that we used to remove all the cancellous board. It was a way how to do it. So we used to do that. And even for anatomic arthroplasty, when I did my first anatomic arthroplasty, we used to remove everything and even to put a cannula into the coracoid to make it totally empty. So there was no other idea than to have a cemented glenoid. It was always no other way than to fix the glenoid. And it failed, probably because of this cemented glenoid fixation, and it failed. And at this period, the Pope of the Pope was near the boss of Bill, and he said, you should not do it. And everybody stopped, because if Neer said you should not do it, nobody did it anymore. And this is the first prototype of Ramon, and we will speak about that later. And it was cemented. The results were good, but not so good. And Ramon did three things. He said, okay, it should work. It was mainly an idea. There was no really lab, not really proof on that. It was not, in other words, it was not really scientific. But he made this draw and said, okay, we need to medialize, to distalize, and he did something else that almost everybody, for us it's very clear now, but he did three things in fact. He fixed the glenoid with screws, which was 30 years ago something, or 35 years ago something very, very innovative, and he distalized and medialized. So he did three things at the same time. And it worked. It worked. Everybody knows this. But look at this. From here to here, of course, there is distalization, medialization. There is also glenoid fixation with screws. Three things. And he reported. He said, in the conclusion of the paper in 1991, he said, now glenoid fixation is better. We have improved the glenoid fixation. But everybody focused on distalization and medialization. So I think that he was really genius for several things. First, because he dared to say no to the well-established, even it was coming from the United States, even it was coming from here. He said, no, I'm going to continue. I think we should go in the way of the reverse. And he fixed the glenoid with peg and screw. So many years after, when it was in 10 years ago, we had a long follow-up for the reverse shoulder arthroplasty. design. I was part of this study. We were lucky enough to have a follow-up on more than almost 2,000 patients. And with a follow-up on more than 1,000 patients, it was a huge series. And the results were good. We can see that for all the etiology, cluster, arthroplasty, massive tear, the results were globally good, but we know that there was a first drop at 10 years, a second drop at 15 years. So it was globally a 10 years prosthesis. That's why everybody said you should only put this prosthesis on all patients. And the rate of notch at 10 years was almost 100%. And of course, at the beginning we said, no, the notch is not a problem, don't worry for that, it's just a notch. But after 10 years and after 15 years, it was a true problem. When you have a notch, you have glenoid loosening, and when you have a notch, you have humerus loosening. So notch was a real problem. So, Ramon make it work. It was a success, thanks to him. Before him, it was a failure. After him, it was a success. But it was a 10 years prosthesis, because after 10 years, we have to face severe complication. In order to avoid this complication, we try to do several modifications, mainly two. The first one, to try to not distalize, medialize, to start to lateralize a bit. You can have two options, in the metal or with the bone, and to modify the neck shaft angle. Of course, everybody knows this picture. It's a picture from Pascal Guerreau, the bio-RSA, just for the younger, or the young surgeon. Just keep in mind that bio-RSA means bony increase offset. When you do graft, if you have a bone loss posteriorly, and if you put a graft, this is a bone graft, it's not a bio-RSA. So if you want to use the name of bio-RSA, you need to add bone to the native glenoid. Unfortunately, we still saw some loosening of the graft and notch with this technique. And this is one of my cases that sometimes you are a bit anxious because you have no more graft and you are this kind of picture. So for me, it was not the solution. So we tried to modify the neck shaft angle. So we tried to go as close as possible to the native glenoid, mean 135. And years after, when we had the planification system, it has been published that if you want to avoid the notch, a good way to do it is to have a neck shaft angle as low as possible, close to 135. So lateralization on the glenoid, it's okay, it's a good idea. With the bone, probably not. To have a lower neck shaft angle, it's a very good idea. So, but it has been done before. This has been done 15 years before. We are here now, but it has been done many years before by Mark. He said that he showed us. He said that we should not do this 155. In fact, what did he say? He said we shouldn't. It's not necessary to distalize and medialize. It's not. You can lateralize and with the 2/3 fill and have a neck shaft angle of 135. That's what he said 20 years ago. And we told him in the group, and especially French people, we said, this is stupid. This is stupid. Ramon told us that you need to distalize and medialize. So if you do this, it's going to fail. We know that. And we were right, because it failed. So we were very, very, absolutely, we said, okay, you should distalize and medialize. But if you look, and Mark reported very honestly his result and said, I have 12% of failure on the glenoid side. But Mark is a very clever guy, and when he looked at all his failure, in fact, the failure was not related to the fact that there was no distalization and no medialization. The failure was related to the position of the base plate. In other words, you should never have superior tilt. 0 or inferior tilt, but never superior tilt. If you have a superior tilt, then you are at high risk of glenoid failure. And he reported the result with this modification to have 4 screws, 5 screws, and absolutely no superior tilt. And then there was no notching and no glenoid failure. I went to visit Mark because I was interested in that. It was almost 15 years ago. Just be careful if you visit Mark. He was a bodybuilding champion. So at 5 a.m. before the BPR, you are at the gym with him. And I have a long discussion with him. I was in his house during many days. And then I think that my mistake was to think that distalization and medialization were the gold standard and mandatory, but no. In fact, it worked thanks to the fact that you don't need to distalize, you don't need to medialize, you need to have a very, very good glenoid fixation. So for me, no more distalization, no more lateralization. We're going to speak of that later. And this is very, very interesting. This is the first patent of Graham. The first one, the very, very, very first one, it's 135, and it's a 230. So this is the case now. You see that this is an anatomic arthroplasty. This is a reverse arthroplasty. And if you try to rebuild this, you can do what we call anatomic arthroplasty, anatomic reverse, and Jour is going to speak about that. So in conclusion, Graham was a genius because he made it a success. Before him, it was a failure. After him, it was a success. So he was really genius. And Mark teach us how to avoid the main complication. So now we have this reverse shoulder arthroplasty, and we're going to speak of that during 2 days. Thank you.
What in the hell is an anatomic reverse? Which way do I go? Is this the company?
Down arrow.
The down arrow. Okay. So, I figured, well, let me go ask ChatGPT, what is an anatomic reverse? And it came back with this answer: there's no such thing. There's either an anatomic or there's a reverse. But if you think about it, there is some value to think about the principles of a reverse arthroplasty when the rotator cuff is intact versus a reverse arthroplasty in the context in which it was originally designed and used, which is in the severe cuff deficient shoulder. And so the question becomes, should you think differently when you put in a reverse arthroplasty when the rotator cuff is intact? Because the basic premise by which the reverse was designed and used was to improve deltoid function in the setting of rotator cuff deficiency. And the question that you have to ask yourself, are the principles of reverse arthroplasty the same in a patient with an intact cuff? So many patients in the US and in Europe get a reverse when the rotator cuff is perfectly fine. And in fact, you repair the rotator cuff. If you do a subscap approach, you meticulously, most of us, repair the subscap because you want to keep the rotator cuff intact in these patients. So what are the principles of reverse arthroplasty? The principles are distalization and to some degree medialization of the center of rotation, with the sense that you're going to make the deltoid compensate and work better in the setting of a rotator cuff deficiency. And as a result of the distalization, depending on how much distalization and how much tension you put on the soft tissues by virtue of that, you have some negative consequences related to stress fracture, sometimes anterior shoulder pain because of the stresses on the soft tissues, and in some patients, dislocation. All of those things are less in patients with an intact cuff, because the intact cuff can protect against dislocation. To some degree, it protects a little bit for stress fractures. And so are the principles of reverse arthroplasty appropriate in a patient with an intact rotator cuff? And I would say the answer is it's not. The principles are different. And the question you have to ask yourself, if that's true, and that's the important question, if that is true, then should you change the implants you select, where you place them, how much inferior tilt, where you put the center screw or the center peg, what size glenosphere do you use? Do you use an inset or onlay humerus? Do you use a 135, 145 humerus? All of those things change how much distalization, how much lateralization, how much overstuffing, how much metal you put into that container that has an intact rotator cuff. And it even begs the question, should there be a different design of a reverse arthroplasty in patients who you choose to do a reverse with an intact cuff? And it even begs the question, if you're trying to do an anatomic reverse arthroplasty, why don't you just do an anatomic arthroplasty? And I can tell you the answer to that question. The answer to that question is because the results of anatomic arthroplasty with minimum 10-year follow-up, published by arthroplasty done before 2015, were terrible. Either because of rotator cuff failure at 10 years in older patients, or because of glenoid failure. And if you ask yourself the question, well, tell me about those arthroplasties done before 2015. No planification, no sense of premorbid anatomy, no use consistently of multi-peg hybrid design biofixation of the glenoid. No sense of using augmented glenoid components when there was glenoid bone loss. So those results, Jill Walsh is probably the most cited article of glenoid failure, 20-some-odd% failure, and another 20-some-odd% glenoid rotator cuff deficiency, minimum 10-year follow-up, was the impetus. That was the driver for more and more use of reverse arthroplasty in cuff intact shoulders. So this fact that if you use the principles of reverse in patients that were designed for reverse for cuff deficiency, and you do it in a cuff intact shoulder, then maybe you need to think about this concept of anatomic reverse, which again, this is from Mark Frankel's work where he looked at the muscle forces and the stresses on the implant. If you try to still use a reverse, but less distalization, less lateralization to try to do that. So the decision making that I think is important is the assumption that there will always be some clear indication for an anatomic arthroplasty in an intact cuff. And typically, you want to do that because the range of motion is better, there are fewer stresses on the spine of the scapula, so stress fractures are less. But there are certain requirements. The negatives about anatomic is that I think it is more difficult to anatomically reconstruct the shoulder. And there are always going to be some problems with the rotator cuff in older patients if you do an anatomic in 70, 75-year-old. Some of those patients will have rotator cuff failure at 10 years. always this concern of subscap failure, which brings up the issue of how do you take the subscap down? Do you take the subscap down at all? Do you do an MIS approach? So addressing the the negatives with anatomic arthroplasty, it's a good idea to pick your patients more carefully. Healthy patient with good intact rotator cuff, and you want to try to restore glenoid bone loss by reconstructing the glenoid to get back to that patient's premorbid anatomy on both the glenoid and the renal side, and you want to avoid certain patients that have higher risk for late rotator cuff failure, particularly patients with inflammatory arthritis. And in patients who do get a reverse, particularly in a smaller patient, smaller size where you can get more acromial impingement and has osteoporosis, you might want to consider an anatomic versus a reverse. And these are the principles for anatomic arthroplasty, which is to try to replicate on both the humeral and glenoid side premorbid anatomy. There's many software solutions today to understand the patient-specific glenoid anatomy, to say when can I achieve restoration of the glenoid within 5 degrees of inclination and inversion of the premorbid anatomy. Can I achieve that with an augmented glenoid of your choosing, and to try to put in an anatomically sized and shaped humeral head to try to balance the soft tissues. So the recommendations, if you are going to do an anatomic arthroplasty, follow the principles of anatomic restoration of the bony anatomy and the soft tissue anatomy. And so an anatomic arthroplasty is not a surgery that uses anatomic components. It's a surgery that uses an anatomic component to anatomically reconstruct the bony anatomy. And that is the singular most important innovation, I think, in the last decade. And hopefully that'll prove out its validity. And if you choose to do a reverse in an intact top, you should rethink distalization, lateralization, and not overstuff quite as much as you would in a reverse arthroplasty in a cuff deficient children. Now there are problems that occur if you follow those rules, and that usually relates to impingement on the acromion, because as you raise your arm up, the tuberosity gets too close to the acromion, which is why people distalize and inferiorly tilt, particularly in a smaller patient. Which then gets to the question, should we be thinking about reverse arthroplasty design specifically in patients for intact? That's it.
Well, Philippe asked me to speak about indications and outcomes of reverse, so that's what we're going to talk about. Thank you very much. Those are my disclosures. Philippe, lots of pictures. JD,
that's why he's the hospital now, I understand.
So these are my 3 take-home points. Not surprisingly, indications for reverse are not just increasing, they're exponentially exploding. The outcomes for total shoulder arthroplasty, as Dr. Iannotti just mentioned, are superior with respect to rotation for sure, external and internal rotation. Reverse has historically had less revisions than anatomic, but we'll talk about that a little bit. And number 3 is not something to take lightly for all of us as we sit here and think about these topics that are so important for our patients. So we'll talk about complications of reverse, modern complications, not the ones Dr. Iannotti was mentioning. So I think that's important to keep in mind. So indications, we have come a long way. Dr. Iannotti, my mentor in 2006, said that we should be careful about the expansion of indications, and it should be done with caution. Because of course we know from Jill Walsh that he said that the best indication for reverse was the one there was nothing else satisfactory to propose. So boy, have we come a long way in 20 years, right? Pretty amazing. Now this article is an article that is often used in the US to support reverse for intact cuff. Andy Jawa is the American version of some French surgeons who think that 100% of arthroplasties, not 80-20, should be done with the reverse. And Andy uses, in a face-off that they had in clinical orthopedics in 2022, Andy used the paper of Jour as the sentinel paper for why he thinks we should be doing reverse in patients with intact rotator cuffs. And if, go for the young people here, or for all of us, go read the article, because this is the sentinel article. Look at this sentinel article, 27 patients, mean age 74. The mean preoperative retroversion was 32 degrees, and subluxation 87%, whether that's important or not. 15% complications, 37% scapular notching. Now you read those results and you say, how could this be the sentinel article that says I'm going to go rush to do reverse on all intact? But that was it, that article. So it's very interesting. Now there's lots of results, so it's hard in a small number of minutes, but I'll just share some of the results to try to give big data, big registry data. So this was the Australian registry. You can see almost 4,000 anatomics, almost 9,000 reverses, and you can see that they looked at endpoint time to revision. And this is what they found, no difference in the cumulative revision, but we're talking about a very short period of time. I mean, 4 years, we all know that's not enough, but 3.5% for anatomics, 3%. They found some interesting early studies that males actually had a higher rate of revision in the early period, and older females, not surprisingly, had higher revisions with anatomic all poly cemented glenoids. Really important key point to talk about as we go through this. This was Lynn Crosby's data. This was interesting, looking at a high number of arthroplasties with one surgeon. And if you looked at people who had a prior non-arthroplasty surgery prior to their arthroplasty, so they did not have a revision arthroplasty, had a higher prosthetic joint infection, PJI, in the reverse group cohort compared to the anatomic. So just an interesting observation. Now, here's some studies that look at intact cuff. So 1,061 studies. You can see the numbers, not huge numbers, and again, we see this over and again. Total shoulder superior for rotation, for range of motion, but an equivalent in this study with respect to revision. Then we said, well, what about greater than 70 years of age? Systematic review just from this year in 2025. Again, same kind of themes. Total shoulder better for motion, revision higher with the reverse. So if you were going to say what's not controversial in 2025, and this might be controversial, but we'll chat. I would say cuff tear arthropathy, massive cuff tear with arthritis, failed anatomic total shoulders, proximal humeral non-unions, most full-part fractures in elderly patients, and tumor resections. What about controversies? What about massive cuff tear without arthritis? We've been talking about that. DJD with an intact cuff, we've been talking about that. What about younger patients under 60? What about four-part fractures in younger patients than 50? What about DJD intact cuff with glenoid bone loss? And what about inflammatory arthritis? So those are all cohorts where you could make arguments probably on both sides of the aisle. But here's to get to your question about the increase across the world. Here's just 3 recent studies, but the UK went up significantly. Look at the US. I didn't know you could go up 1,373%, but you can. And look where we are, 2016, Australia, New Zealand, this graph on the right. So you see these dramatic changes in people's perceptions, surgeons' perceptions of what they should be doing when before they were thinking anatomic and reverse for salvage only. And obviously we have completely inverted that. Patients under the age of 60, Franco-American from UCLA just published this in 2025, however. So if you look at those patients under 60 compared to over 60, 1.53 times greater risk of complications if you do a reverse under the age of 60. And if you think about what we've been talking about, total shoulder, our complications are failed glenoids and soft tissue. subscap failure. Posterior superior cuff gives way because it's an older patient, so with time, as we know, the cuff gives way. On the reverse side, we get this problem, okay? So we want to say, oh, it's 1%, it's 2%, it's 3%. Start doing the math of all those thousands and thousands and thousands of patients and multiply it by 3% or 2%, whatever number you would like. And that's a lot of patients that we're causing a problem that we do not have a solution for in 2025. We had a wonderful face-off with Dr. Iannotti and Dr. Jour at the American Shoulder and Elbow Surgeons annual meeting, talking about this topic, about anatomic versus reverse. And I asked Dr. Jour, how many scapular spine fractures have you had in anatomic total shoulder arthroplasties in your career? And he very quietly said 0. Didn't want to say too loud. And of course, catastrophic bone loss on the glenoid side can lead to us having an unreconstructible shoulder. So if you look at a number of studies, this is kind of how I would summarize for the group thinking about acromial and scapular spine stress fractures. Once you get it, we're toast, is the bottom line. Does that make sense in French? Okay.
Bird toast.
No good.
Bird toast.
We're not good. So you get decreased results. ORIF is no better than a non-op group Christian showed us. ORIF is better than the non-op in a more recent series, but not as good as prior to when they got the fracture. So they never get back to as well as they were doing prior to that fracture. We changed something in that shoulder kinematics that is not happy, even if we can get that fracture to heal. This is a study you guys should all be focusing on. Our friend George Athwal in Canada, 2025. These are 16 studies, 346 patients. This is indications for revision of reverse. So our reverse has failed, and we have to do a revision. 32% complication rate, 27% re-revision rate. This is not a benign operation. So when we think that when we're saying to the world, this is the operation of choice for everybody, all comers, come get your reverse, I would say, let's have a little caution. Just a little bit, and we'll chat about it and see. Here's 2 things that I would throw to you, because this wasn't my topic, but it's a passion of mine. Anatomic total shoulder with a hybrid glenoid, and for me, hybrid glenoid means a metal post that allows bone ingrowth. And there's a number of companies that have them. Has all but eliminated glenoid loosening as a problem. 10-year follow-up, most recently published in JSES this last month by Tim Codd. 10-year follow-up, 98%. Multi-center study, 98, 99%. So we've really done a great job. But as Dr. Iannotti has mentioned, this is a real problem. And I would say this, for the young folks here, would be the next frontier in trying to better understand how can we take care of the soft tissue problem on the for anatomics. So my 3 take-home points: indications for reverse have exploded, outcomes for total shoulder superior for rotation, reverse has less revisions, but big but with the data that I've tried to share with you, and this number 3 is something that we're going to all have to keep an eye on. So thank you very much for inviting me. It's really a pleasure to be here for my 5 hours.
I like to talk about planning in front of Joe. I never like talking about lethargy in front of Vigil. So why do we plan? Well, it has been shown by Joe that 3D CT scans are the gold standard now. And he has proven in many different studies that using standard instruments and 3-dimensional planning is better than standard instruments and 2-dimensional planning in both anatomic and reverses in vitro and in vivo. So we have now many software, and what do these software do? Well, they allow us to have a preoperative plan where we have humeral and scapular segmentation, which is a 3D reconstruction and labeling of the bones. Then we are able to determine scapular and humeral reference planes to calculate the inversion, inclination, and subluxation. And in most software now, we're able to do a virtual implantation of the arthroplasty. And once the arthroplasty is inside, we can simulate part of the result, because we can only simulate right now passive glenohumeral range of motion, which is a big limitation of this software. Now all the companies have many software available, and some studies have been done to try and determine which is the best software. So they compared the software, they found considerable variability between the software, showing that some had greater version measurements, the inclination did not change much, but it's like comparing miles per hour and kilometers per hour and trying to say which is best. It doesn't make any sense. What is important is to understand what is normal with the software you're using, what is pathologic, how they work, and whether the method is validated or not. So it's important, I think, for us as surgeons to understand how they work. And so the first thing is to understand the different steps. So the first step is the 3D segmentation. Then the software will determine the glenoid plane, then the scapular plane, then the transverse axis, and then calculate humeral subluxation. So if we look at each of these steps, the first step is 3D segmentation, and so the goal is to transform a two-dimensional image into a 3D model. This can be done manually in a semi-automated fashion or in a fully automated fashion. So manually, there's a guy going around each of the contours of the bones. No one does that anymore. Then semi-automated, this is done by many of the software available. It uses bone density as a threshold to keep only bone, and then you separate each bone manually, especially in cases of severe arthritis. And then it can be fully automated using either statistical shape model, machine learning, a combination of both. Then you need to determine the glenoid plane, because with this glenoid plane, you will be able to determine glenoid version and inclination. Again, many different methods, and it's important just to know that these exist, that they are different, and this is why we have different measurements. So one method is the manual selection of anatomic landmarks. So we have these 4 points around the glenoid, superior, inferior, anterior, and posterior, and you use 3 of these points to calculate the plane. Another way could be to do an automated selection of all the points on the glenoid face. And so you have an infinity of points on that face, and then you try to determine the best fit plane going through all these points. And then another method that has been used is assuming that the glenoid is not flat, it is concave, rather than using a plane, using the best fit sphere that matches that concavity. Then we need to calculate the scapular plane to determine glenoid version and inclination. This can be done, again, different methods. The first one is the manual selection of 3 anatomical landmarks. This is the method determined by the International Society of Biomechanics to determine the scapular plane. So using the center of the glenoid, using the most inferior point of the scapula and the most medial point of the scapula. The problem is that to calculate the glenoid center, we again have different methods. One method is to use the intersection of the points that we've seen before. Another method is to use the best fit circle that matches the inferior rim of the glenoid, and then have the center of that circle. Or another method is to have an infinity of points on the glenoid face and calculate the mathematical center of that surface. Then I told you the most inferior point and the most medial point, and this gives you a plane. This is one method. There's another method coming from Lausanne, where they do a manual selection of 10 landmark points. So the 5 red dots and the 5 blue dots. The 5 blue dots are in the supraspinatus fossa, and the 5 blue dots are in the pillar. And if you have these 2 lines, well, you have a plane, and this gives you a scapular plane. And then you can have a fully automated method where you take an infinity of points on the scapular body. This animation is not accurate because it includes the glenoid, the acromion, and the coracoid, which is not the case. It should only be on the scapular body, and then you have the best fit plane through this body.
Can I ask a question?
Of course.
Do you think any of these methods in a deformed glenoid pick the center of the glenoid that represents the premorbid center of the glenoid?
Well, this is why the last method does not use the center of the glenoid at all.
Right.
Well, actually, the second and the third, but no, I think the first method, they are valid on a regular scapula, but on a deformed scapula, it's very difficult to have this center.
Unless you define
The
the
glenoid.
premorbid
Yeah, exactly.
glenoid and then pick that as the center.
Yeah.
Because the presumption is that the plane of the scapula for which you are developing your coordinate system was the original glenoid before the pathology.
The
And
only
I think that's where sometimes there's differences between
yeah, definitely.
method 1, method 2, method 3.
The only issue I have with that is that the statistical shape model is great, and I think it gives you all the information that you need to plan an anatomic. But when we call it premorbid, it's wrong, because it's not the premorbid anatomy of that patient, it's a statistical mean of a healthy guy that is not that guy. But for the center, I think it works.
You don't know how he's born with.
No, we do not know that. We do not know the true premorbid.
It's better with the bolt model?
Well, we had this
We don't
discussion,
know
I think
that.
it's the same.
Yeah. We proposed that study to materialize about several years ago, and we couldn't agree on the cohort of patients to study. And in some measure, because we did not have enough of our samples to provide to them through a data use agreement. So it was all logistic, tactical, but that was the question. Does the vault model compare, or how does it compare to statistical shape model? Realizing that both of them are imperfect. Neither, there is no true north. I mean, it's a guess.
I think both work to reconstruct the glenoid, but not the rest of the scapula probably.
JD, do you think that there's a difference between the automatic segmentation and the hybrid manual plus auto?
Yeah, there is. The advantages of fully automated is that it's reproducible always, and it also reproduces the mistakes. So if you know how it works, then you will pay attention and see if the segmentation looks off, and then you will say, okay, here's a mistake. Anatomic has more variability, I will show you that, but it will be able to correct big segmentation mistakes, of course. For the transverse axis, so it can be either the line that we see here between the glenoid center and the most medial part of the scapula. Again, 3 methods to calculate that center. It can be only the red dots here, the fossa of the supraspinatus, or it can be a fully automated method again. You take the Y view on every single slice, and it's the intersection of the Y, so the yellow dot here, and this creates you a curved yellow line, and so the best fit line going through that curved line is or can be defined as the transverse axis. And you can see just from these drawings that on the C on the lower right and the line on the upper right, there's a big difference, and so of course you're going to have different values of inclination. It does not mean that one is right or the other one is wrong. It just means that there are different ways of measuring the same thing. Vergent inclination, different methods. Joe, I think you recognize that picture. And so it can be either the glenoid plane relative to the scapular plane, for inclination the glenoid plane relative to the transverse axis, or you can use the best fit sphere that we've mentioned previously. And then version is the angle between the scapular plane and the glenoid best fit sphere center line. And for inclination, it's the same thing, but using the transverse line rather than the scapular plane. Humeral head subluxation, again, different methods. Either you use manual selection of 5 landmarks of the humeral head, you can use automated identification of the best fit sphere on the humeral head. And to calculate subluxation, different methods. Either you use subluxation relative to the scapular plane, subluxation relative to the glenoid plane, or rather than using values, you can use a percentage of volume that is on each side of the scapular plane. So is one better than another? We alluded to that quickly. This study, they said that the best method is the Sentinel paper, as you said before, showing that the manual method or semi-automated method is the best using these landmarks. But what they did is that they compared these landmarks on the CT scan to the same landmarks on the true scapula. So of course, if you use the same landmarks on both, what you prove is that the CT scan is accurate.
That was our only question, because in 2005, we did not know
if a CT scan is
But the
accurate now.
3D CT is actually even
So that's
an
great to
accurate
hear,
test.
because this is quoted in all the papers saying that this is the best method, which
Yeah, only because it's self-fulfilling.
exactly. So this is just for discussion, but so we found these studies found different values, but again, it's not very relevant. What is what we just discussed with Bill, manual technique. The engineer subtracts the humerus from the glenoid. So here you can see on the manual segmentation, on the right, it's pretty accurate. On the automated segmentation, there's a big hole. This is wrong. So when you are a surgeon and you look at this, you look at the CT scan and you know there's a mistake, and so probably you will not be able to fully trust the values on this specific case. But what is interesting is that this study has been done to pick the points manually, and you can see that the variability in picking the most medial point in the scapula is very high among highly trained surgeons. So this means that there is also high variability when it is done manually. So what next? Because these software, they are evolving, and I think it's pretty exciting what we're now able to do, because we have now ability to plan, but we still do not know really what to plan for. Many studies have been done looking at that, and you can see again variability between surgeons looking at the mediolateral entry point or the anterior-posterior and superior-inferior entry points. Now there are machine learning software and algorithms that are going to help us to predict outcomes. Maybe they will help us predict implant position or decide between anatomic or reverse. Right now, this is starting to grow a little bit, but it's not yet fully available in all companies. This is a subject that is very dear to me because it was my PhD, but I think that including the soft tissue in our planning software will also be something that will be helpful. Maybe not just the visualization that we have now, but being able to understand the elongation of the muscle, being able to precisely understand the fat infiltration of the muscle, and maybe use this data for future algorithms, I think will be helpful. Also in the future, and the future is now, we're going to include the position of the scapula and the scapulothoracic joint, because right now this is how we're analyzing our patients, looking at the scapula floating in the air and putting the humerus in front of that. But if we add the whole rib cage, maybe we realize that the scapula is not in this position, but actually in this position, and maybe the humerus should be adapted, maybe the version of the implant should be adapted. And this is the work from Arnaud, who's in this room, and it's the continuation of what we've been discussing, including the premorbid, not only scapula, but I think the premorbid shoulder. So we're working on including the premorbid scapula, including the premorbid humerus, combining the two to have the true premorbid position of the shoulder for anatomic, but also for reverse, because probably this excessive tension, excessive elongation leads to scapular fracture or other complications, maybe instability. And again, another subject that is also very dear to me, and we're trying to include this in our planning software. Christian Gerber has shown that there is great variability in the shape of the acromion. Some have a flat roof, some have a Swiss chalet type of roof. And we found that patients with arthritis have a posterior acromion that is much higher, flatter, and shorter. And I think in the future we evolve from Gilles' classification that was in 2D to including the entire scapula, to including the glenoid in 3D, to probably including the entire scapula and trying to understand how this works as a whole. Thanks a lot. Just quickly, we know that 3D planning is better. It helps us improve implant positioning. Several methods exist, and it's important to understand. None is better than the other. We need to understand how they work and what is normal and pathologic, and the future is exciting.
So I was asked to talk about how to replicate planification. There's going to be a little bit of overlap between what Dr. Werthel was saying as well. I have no conflicts. I work with this crazy guy who was supposed to be here, but you guys are stuck with me today. Over the past 100 years, we've come a long way in how we plan our shoulder arthroplasties, progressing from plain x-rays to 2D CTs to now in the 2010s and 2020s, how to enable and enact our three-dimensional planning using intraoperative navigation. And a study was done looking at how many publications utilize this 3D planning for shoulder arthroplasty, and steadily increased as well to now over 50%. And does planning really matter? Well, I might be the black sheep here today, I think, and take a little bit more of a nihilistic approach. And JD's talk was talking about accuracy, but what I'm going to be talking about is precision. And so preciseness is how closely all of our replications cluster together, while accuracy is getting towards a gold standard. So when we're talking about enabling planification, we're talking about increasing our preciseness, not necessarily our accuracy. The accuracy comes from all of the background biomechanics and research that we do. And so, looking at systematic reviews, we have good concordance of our planning relative to the types of implants that we're using, where we're placing it. But what we still don't know longitudinally and clinically is whether this really truly matters, and there needs to be a lot of research done for that. Similarly, how good are we at planning? So when we're talking about the preciseness of these software, we also need to look at the preciseness of us and what we do. And so this was a really nice study with 9 surgeons, very well-known surgeons, looking at how precise they were, and in fact there was a low correlation between the surgeons themselves, but interestingly, with a delay of them planning themselves, they were even lower than between surgeons. So depending on the day and depending on the anatomy, we may plan this differently. JD talked about this as well, but what we're doing when we're taking our planning software is we're taking 2-dimensional imaging in the plane of the scapula, and we're converting these into 3D volumetric renderings. We do have to exercise caution and understand the limitations and how each software processes this and what that means, and that there are variations even in up to 10 degrees for humeral head subluxation, 5 degrees of version or inclination, depending on whether this is automatic or semi-automatically segmented with a best sphere, such as the 28 blueprint systems, or more semi-automatic and manual segmentations as well. But interestingly, in studies where a surgeon still makes their own measurements off of these reformatted scapulas, they probably have a higher reproducibility. When we're looking at limitations of 3D preoperative planning, this is an example on the right. Imaging quality plays a factor. If there are artifacts from metals, that can really degrade the imaging quality and influence where you're putting this. All of the preoperative planning software is really limited in terms of bone quality and soft tissue factors, which is something that we still don't really understand. There is also a surgeon learning curve to how they plan and where they are putting the implants when they're doing this. So the ways that we enact planning are patient-specific instrumentation, computer-assisted navigation, mixed or augmented reality, and robotics. So these are all the ways that we implement this. The benefits of PSI guides, patient-specific guides, are that they increase our preciseness and our precision and help us enacting our plan. This is really important for complex deformity reconstruction as well as uniplanar version reconstruction. So this is a patient here with about 98% vault loss with a custom implant and an off-center peg. And so to be able to actually get enough fixation, PSI guides or something similar is very important and critical to be able to replicate your plan in the operating room. The drawbacks to this is the cost for just the planning instrumentation themselves are variable, let alone any custom implants that you're doing. There is also a timing and a production delay. So if you have a patient with any complexities over 6 months, that planning is likely to not work anymore for your patient, depending on the pathology. PSI guides also don't talk about depth of reaming. Beyond PSI is this computer-assisted navigation. The most representative company is Exactech, where they use a screen with a reference guide that helps you determine your version inclination and start point, also screw lengths and things like that. They have a very large database because of the way that they do their studies. So over 16,000 patients, their version inclination and their start point can be measured very accurately. Similarly, we see in other clinical studies, including a multi-center prospective study, that our improvement to plan and our concordance is higher when we're using these PSIs or navigation rather than just manual instruments. Interestingly, when we look at computer-assisted navigation, these surgeons had an 8 times odds ratio of using some form of implant and augment when they're doing these surgeries, probably because they feel that they know the anatomy a little bit better. Moving on from that is a mixed reality and augmented reality. So we're taking the screen of the computer-assisted navigation and putting it on our face with a head-mounted display. The 2 most commercially available platforms for this are the Innovis Arvis and Medacta, and this is an example of the Innovis system here. So with the version 2, we can actually see the depth of reaming, and we can double check where our implant has been placed relative to our plan to see if we like it. All of these need an array that go on the coracoid, so there is a theoretic chance of a coracoid fracture as well. Benchtop studies using the 2 different assessments show that inclination, version, and start point are all relatively improved and accurate compared to our preoperative plan. Clinically, using the Next AR Medacta series, we saw that in actual patients, the MR cases are within 5 degrees of your plan, with standard instruments being within about 10 degrees of a plan, and it does increase your intraoperative time by about 10-ish or so minutes just based on segmentation. The next step of this is going to be robotics. There's not a lot of this out right now in terms of research. The theoretic benefits, though, are that we have better data acquisition for research. We are able to see range of motion assessments, consider soft tissue balancing, and this concept of an off-axis reaming and implantation, which potentially could limit the amount of soft tissue retraction that we have to do. It can also standardize teaching as well by having a more standardized approach. The detriments, though, are the cost and the infrastructure and how we reimburse for this as well. Right now, this is really the only study. It's a benchtop study looking at the difference between robotic arm-assisted PSI and manual. It is a bit of a cherry-pick study. It's a manual without any sort of standard guide, and the robotic arm and PSI is very similar. Right now, the two commercially available platforms are the ROSA and the Mako. Both are similar, however, they do enact the surgical effects differently through what's called the effector arm, which is the part that interacts with the patient. So the Mako utilizes a burr in most circumstances, and it has haptic boundaries to help you paint sort of the glenoid and remove the right amount of bone. So in general, planning improves precision. It is important, probably more for deformity or unusual cases. You do have to understand what software you're using and how that varies over time. But all of these can, within probably 5 degrees or so, enable your preciseness in the operating room. But future directions that we need to understand is, how does this even matter clinically? How can we model the soft tissues? And as we were talking about, what is the scapula doing? So I ask everybody, everybody's familiar with this, just look at the scapulas, don't look at the arms. And it looks a bit unnerving. It's not real, it's completely fake. It helps us see impingement-free range of motion, but it doesn't tell us really anything else. So sort of the next step here, what we need to do is we need to have technology to be able to look at what is normal and what is pathologic. So these are our 4D CT scans that we've been collecting on patients to try to determine what the movement is of the scapula, the SC joint, the AC joint, and the glenohumeral joint relative to the chest and the thorax, to see if we can actually come up with some sort of planning. Maybe moving from an anatomic axis to something more akin to a mechanical axis, very similar to spinal pelvic parameters in hip arthroplasty.
Thank you, Philippe. So subscapularis is the future. So to approach the snug mass, practical approach. To approach the shoulder, you can do either tenotomy, a peel, or lesser tuberosity osteotomy, that can be anatomic arthroplasties. And the results show that the LTO maybe has a better healing rate, but may compromise bone stock in the long term if it does not heal. But on the other hand, the patient-reported outcomes are the same, whatever the technique. So in the end, you should use what you are best, most confident with, to be reproducible for the patients. For the reverse arthroplasties, one of the questions is, do we need to repair the subscap? Because it should work without a subscap. So for stability first, meta-analysis shows that there are less instability with reverse arthroplasty than the healed subscap. And also for the internal rotation and the Compton score, so it seems to be a good idea to fix the subscap when you do a recurse. So now we are moving forward on the subscap sparing approach, which is quite recent, which was first described by Laurent Lafosse 15 years ago, but he used it with an superolateral approach, and he took down a part of the deltoid and then went through the rotator interval. Then Alexander Lederman described it through a deltopectoral approach, and you could obtain a good view for curved arthroplasties and massive rotator cuff tears, but he concluded that it's technically difficult and the inferior humeral osteophytes cannot be removed from here, and he does not recommend to lateralize too much
with this kind of approach. And then more recently, at Jaco in Nancy, developed the anterior muscle sparing approach, and he published his series with all kind of indications and 5 primaries with an implant cuff through a deltopectoral approach, and he performed also inferior release here. So he goes under the subscap, elevates it, and does an inferior release on the humerus from here. And based on 45 patients, he says it's safe and reproducible, and now he's teaching it a lot, and people are doing it more and more. And in case with an intact cuff, he does a supraspinatus peel to get access to the joints. So I thought it was a good idea because subscap seems important. So if you can keep it and don't worry about healing your LTO or your tendon, it's better. So I tried it, but it is very different from taking down the subscap. So there is a learning curve for the hip shoulder as well. And an important part of it is the position of the arm during the surgery. You have to move it so you can expose the subscap. So you have to do adduction and retropulsion, which is not very easy at the first time when you do it. The ancillary you use is an important part of it, because if you have an ancillary that comes from the front of the humerus, then you have to have a lot of external rotation of your arm, while if you use an ancillary that allows you to come from the top of your humerus like that, it makes it much easier. Also, the cut is more difficult when you have to do the cut from in front of the humerus rather than upward. The post-op is maybe easier, at least more reassuring for us, because you don't have to worry for the subscap healing and to protect it, so you can tell your patient just remove your sling whenever you want and do what you want within the pain limits. And then the question is for the intact curve, because from this paper from Sugaya's team, what we think of the insertion of the supraspinatus and hyperspinatus, here is the greater tuberosity, and it's supposed to, we think supraspinatus is here and infra is here, but they did this anatomical study, and actually the infraspinatus goes very in front of the greater tuberosity. So if you do a supraspinatus peel, it's more like a supra and infraspinatus peel, and then you have to choose whether you elevate the infra or the subscap. And for me now, I think we have more follow-up with subscap insufficiency rather than infraspinatus insufficiency. So maybe it's the future. I think it is, and I will try to improve it. The technique, Adrien's technique is very standardized, combines the advantages of the deltopectoral and the superolateral approach, but maybe not for all the indication, at least not when there is an intact curve. Thank you.
Maybe it's time. Hello, everybody. Thank you for being here today for this lecture about innovation, research, development, and leadership, a roadmap for innovation. It's really my pleasure to introduce Professor Joseph Iannotti, Professor of Orthopedics at Cleveland Clinics in Florida and Chief Academic in Innovation in the Cleveland Clinic. Professor Iannotti led the Cleveland Clinic Department of Orthopedic Surgery from 2000 to 2018 and served as the orthopedic and in the Orthopedic and Rheumatology Institute. You hold 89 US patents and authored more than 450 peer-reviewed publications, review articles, and book chapters. I'm not going to go into too much detail about your presentation. You'll do it much better than I. However, I will say that we are incredibly lucky to have such a speaker here at the American Hospital in Paris today. You are emerging. You will explore the dynamic relationship between discovery, research, clinical research, technical research. And definitely, we all know that the success depends not only of they depend much more than leadership and creation of team than the reality and of the quality of the technology. Both are necessary, but if you just have the technology, you have nothing. He will also share insight about his experience, your experience in pre-surgical planning, surgical navigation, and orthopedics in orthopedic surgery. Please join me in welcoming Professor Joseph Iannotti. Welcome.
Well, I think we just learned how someone could be well suited to be CEO of a hospital, because he essentially gave my talk without looking at any of my slides. So job well done. So this is a pleasure to be here, and thank you for the invitation. I am going to talk a little bit about my personal experience over 40 years in terms of research and development of new technology and some of the attributes of leadership. All of those things are very, very important in terms of developing new ideas and new concepts for innovation. So these are my conflicts of interest, and given the nature of the talk, they're all relevant in some shape or form. So I am going to talk about the process of research and development. They're interrelated. They're somewhat different from one another, but they're interrelated. It's important, most people in this room, if they are going to be successful as clinicians or surgeons, they are, in many respects, leaders. You're a leader of your clinic, you're a leader in the operating room, you're a leader in your hospital, and some of the attributes that are important in developing new technology are equally important as a leader in clinical care. I'm going to talk a little bit about why we're here, what's the value of going to scientific meetings or symposia, and I'm going to talk a little bit about my own personal experience over about a 20-year period of time. I talked a little bit in the smaller meeting about what's your question, and that sometimes even over a 40-year period of time, you only have an opportunity to answer, truly answer, a couple of important questions. And so it's important to pick your questions carefully. So we'll talk about that. My journey started back in 1979. When I finished my medical school training, I started a residency at the University of Pennsylvania. This was my mentor, Carl Brighton, and I did a lot of basic science research. So I got a PhD in cell biology after residency, and then I ran my own cell biology lab for many years. And why is that important? Because that rigor of asking the right question and developing the tools to answer those questions did not happen in residency. It happened as a graduate student and subsequently after that. And I was very fortunate at Penn, where the Carl Brighton and others understood bioelectricity. What causes bones to heal, what causes non-unions to occur, and how you can apply electrical signals to bone to treat non-unions. So I saw in my residency and throughout my young career how you go from research to developing a product and bringing that product to commercialization. And that learning experience really was very formative in my own career as a shoulder surgeon. And I did start after cell biology realizing, well, if I'm going to be a shoulder surgeon, what good is it for me to be a cell biologist? I have to start doing something that relates to shoulder surgery. So that guy over there is Jerry Williams. He's one of my best friends, and we started on this adventure to understand initially shoulder anatomy and looked at relationships between the bones. We looked at the issues of conformity and constraint in kinematic motion in anatomic arthroplasty, and we looked at the issues of constraint and conformity as it potentially related to glenoid component loosening. And this is sort of my formative year. So the first 15 years of my career was basically basic research and some clinical research. So what have I learned? I learned that research is by its nature a process by which you gather new information, and by its nature it's exploratory, versus development, which is taking new knowledge and applying it to a practical product that might be useful in the real world. And if you're a doctor or you're a bioengineer, that usefulness has to be related to a patient or to a disease. If you're a product designer, maybe it's an iPhone, so it doesn't do healthcare, but it in the commercial market. So taking an idea, taking research is the research part, and the development part usually is a product of that effort. So these are very interrelated processes. They're iterative. You ask a question, you get data, you get information, you may change your hypothesis, you may change your thinking, and you go back through this iterative cycle. And on occasion, especially if you're paying attention, you might understand that you have created new intellectual property. And clinicians are best at this because they see the difference between research and new knowledge and gaps in patient care. And that perspective allows for some clinicians to say, I think I have a better way of treating a patient. But many fail because they don't recognize the intellectual property or they don't know how to protect it. And then you start this development cycle. And again, it's much like research. It's an iterative, cyclic process, collecting data, analyzing data, refining your question, and continuing that process. And if you're lucky, that product could be useful. It may change clinical practice, and you go through the process of going from development to commercialization. That is a big barrier, to go from development to commercialization. The good part is, if you're an academic person, both of these processes result in academic productivity. They result in papers, they result in lectures, they result in something that promotes your career as an academic physician. The other thing that's very important to realize, that if it's a well organized team and effort, there's this interaction between development and research, and it goes back and forth, sometimes like a ping pong ball. Things you learn in development become new questions for research, and new questions in research can sometimes lead to new products or new intellectual property. So what's the difference between invention and innovation? An invention is the new knowledge. That's the intellectual property. But it's not a product unless you innovate and take that intellectual property to execution. And what's critical to this success? The number one is curiosity. And curiosity asks the right question for the right problem. And if you have determination and persistence, and this is what takes time, then you might be lucky enough to go from invention to innovation. It's also important to have critical doubt. You can't always believe that what you thought at the beginning is the path that you need to take for 10 years. This is this iterative process of re-asking the question, doubting that maybe your premise was correct. Sometimes it's not correct. You need to switch gears. So this is my saying, do not breathe your own exhaust. If you listen to everything you say and you actually believe that it's true, you're going to be wrong a lot of the time, and you're going to go down a path that is failure. And you have to listen to constructive criticism. When somebody you know and you respect says, I'm not so sure you're going down the right path, you had better listen. That doesn't mean to say you change your path, but you should not disregard it, because they may be right. And if you say, what's the value of this presentation to me? It's because I'm going to present something at the very end that I'm working very hard on, and I expect people in this room, assuming you know the field, to give me feedback, good, bad, or otherwise. So what's good research? Good, and I learned this from my mentor literally 40 years ago. He said good research means that the data stands the test of time. If you do good research, that data will always be useful to somebody. Your interpretation of that data is going to change because your knowledge of what you know will likely change over time. But good research, data done well, good research stands the test of time. So what is the difference between knowing and understanding? Okay, knowing is the understanding that what you think you know is new and not previously known, and most importantly, important to know. If it's not important, and you know something that nobody cares about, it may be in the future, but not at that point in time. And understanding what is new, if you think about that, understanding what is new means you've got to know everything there is to know about that subject so that you are not thinking that you know something that just because you haven't read the literature or you haven't really studied the problem is not so new. Somebody else already knows that. What's the difference between projects and programs? Projects typically are short-lived. Simple question, how does this work? When does this happen? Programs typically answer the question, why? Why does this happen? That is a much more difficult question to answer because you have to know all the other things and go one step beyond to explain why something happened, not the who, what, when, and where. So the development cycle has some critical elements. First, you have to understand that you have intellectual property. I can tell you how many times that goes unnoted, and it is disclosed in a presentation, or it's disclosed in a casual conversation, and it potentially is lost. So you have to know and understand when you know something that is truly novel, is clinically relevant, fills a gap in knowledge, and you protect it. And then you have to understand, does it matter in the market? Because if you're going to sell something, somebody has to buy it. And nobody's going to buy it if they can't make money selling it in the marketplace, be it a commercial product, be it a healthcare product, be it a technology, be it a device. It has to have clinical utility. So there has to be a business plan relatively early on to say, I'm going to invest my time, my money, my talent to actually develop this product. And then this gets to the leadership. You have to build great teams. Nobody is smart enough, skilled enough, capable enough of doing everything from invention to development to commercialization. And then you have to figure out how to monetize this intellectual property. Again, all of these are lectures unto themselves that take a lot of complexity to go from invention to innovation to commercialization. So this is a quote from Prosper Eckert. He was the developer of the ENAC, the first major complex computer around World War II. Great conceptions are worth little without the precision of execution. And you, as an inventor, as I just said, you cannot do this process by yourself. You have to realize your skill and your deficiency in skills and build great teams. This requires leadership. And, you know, I guess this is another quote that I think is relevant. Success is the ability to go from one failure to another with no loss of enthusiasm. That's probably the typical definition of an entrepreneur. They never think they're going to fail. They are persistent. They keep going and going until truly they run out of money. So what are the qualities of leadership? You got to build great teams. You got to have this combination of inspiring and nurturing. You have to be competitive, yet collaborative, and non-hierarchical esprit de corps. Now, if you think about this for research or development or running a hospital or running a great OR team, these are the same leadership qualities. You have to build great teams, you got to inspire and nurture, and you've got to be competitive yet collaborative. So inventors and innovators are bridge builders. They're capable of speaking many languages. What does that really mean? It doesn't mean you have to be an expert in software development. It doesn't mean you have to be a mechanical engineer and know how to run a CAD system or how to 3D print. But you have to know enough about all of those things in order to build those teams and to communicate in their language sufficiently to understand how that team should function as it's sort of like if you never know what a nurse does and you don't know what a circulator does, then you'll never know how to use those people in your operating room as a cohesive team. Same analogy. So, another thing, this again, lesson learned. Selfish leaders generally do not succeed. And why? Because the best and the brightest people will never stay with a selfish leader, because there's no opportunity for them to grow. So the best people will leave selfish leaders. You need a combination of thinkers and doers. Not everybody can be cerebral and talk about the theory of somebody has to actually do the work at some point. You have to build that team. And this is true if you're running a company, if you're running an academic medical center, if you're running an operating room. Open-mindedness. This gets to the issue of don't breathe your own exhaust. This gets to the issue of critical doubt. You have to be willing to listen. You have to be willing to accept that you might be wrong and you might need to modify what you're doing in order to get to the right. And there's a difference between persistence and stubbornness. Okay, stubbornness means you don't listen. Persistence means you're focused and you're committed. But that doesn't mean to say you can't change direction. And Steve Jobs is probably a good example of somebody who had this balance between persistence and stubbornness, meaning he was able to persevere and embrace new changes. So why do we go to meetings? Why do we go to places like this? It's the people. It's the exchange of ideas. It's the things that we did in the small group discussion. We had very honest discussion about things. Some of us shared things that made us vulnerable. I said things that I would never say in a room of 200 people. But I said them in a room where it was a smaller group. And you learn, you listen to other people, you exchange those ideas. So this is a common quote that I think is true about sharing knowledge. Common knowledge is common. But how you put those ideas together, and they may come from different people at the same meeting, but knowing what you know and understanding what you know, sometimes you take ideas from 2 or 3 people and you create new idea. Because the people in the room, even though they contributed to those 3 things, they did not put the pieces together. They did not connect the dots. That is not so common. So new ideas sometimes come rather intuitively. I would say some of the things that I came up with were sitting in a pool, just really deep thinking. And I say, that is an idea. That intuition, that sense of discovery, and sometimes it's in the lab, sometimes it's after years of research, that comes from years of thinking and knowledge. That's why I said earlier, you got a 30 or 40-year career. What are your 2 or 3 questions that you're truly going to answer? Because you probably don't have that much time to answer in a deep way more than 2 or 3 things. So when insights come from multiple sources, and again, this relates to travel and discussion, these are way new ideas are born. There are 4 types of innovation. This incremental, which is typically what you see in device companies. They tweak this prosthesis that's working well, they're trying to make it better. Architectural, they don't really invent anything new, it's really developing. It's like, going from Uber to Uber Eats, okay? Got the technology, I just redesigned going from Uber to Uber Eats. It's not new innovation, but it's a new method of getting some outcome from an existing technology. Then you've got disruptive and radical. Radical are usually people who get a lot of criticism for a decade or longer before maybe some people start to believe that their thoughts have some merit. So they're in these 4 groups. Very little is radical. There's probably 10% that's truly disruptive, and most of this is incremental. And you've got the cycle of time versus performance, and it has 5 cycles. The first phase has very little in the way of performance and takes a lot of time. This is the early incubation of ideas. And then you've got this sort of linear growth, but a lot of risk. It costs you a lot of money. It takes a fair amount of time. And then you've got this linear growth where this clearly becomes adapted. This is sort of like preoperative planning, 10 years after it started. And then you've got this sort of growth phase and plateau phase where there's continued to be innovation, refinement, but it kind of flattens out in terms of performance. So here's my case example. And this is literally a 20-year journey related to preoperative planning. So this started in 2006 with the thought that it was important to understand the anatomy of the normal glenoid. And that question was asked because I was interested in bone loss, glenoid bone loss, and how to treat glenoid bone loss. So it's hard to define loss when you don't know what was there before the loss. So this was the journey, and we didn't have a way to measure it, so we had to develop software. And I worked with some talented software engineers, and we studied normal glenoid anatomy. And when we did that, we began to understand that the shape of the normal glenoid is very consistent from person to person in this room. And that the only real difference is not the shape, but the size and how you can place that object into a scapula to reproduce the anatomy. That was the aha moment in 2008 that we could say, oh, I can define normal anatomy from pathologic anatomy. And that was the inspiration to say this can become a preoperative planning tool for surgery. So that was 2008, 2009, and then it was the arduous task of filing patents and building a team and creating the intellectual property and the device to do preoperative planning. So that was started 20 years ago. And that's sort of on the plateau of that S-shaped curve at this point in time. Then the thought was, well, that's great. I can understand the anatomy. I can do preoperative planning. I can put different implants into the software. But how do I take that information from the software and execute it at the time of surgery? I want to take this implant and put it in this position in this patient. So this got to the whole question of patient-specific instrumentation, and that occurred around 2009, 2010. That's when we formed a company called Custom Orthopedic Solutions that eventually sold that intellectual property to Zimmer in 2011 and ultimately sold the company to Arthrex in 2015. So you can see from the time of research to the time of selling the company was close to 10 years. And that's actually pretty fast. It's not uncommon that it could take longer than that. But then you kind of realize that patient-specific instrumentation, although they come in two types, 3D printed or adjustable instruments, have, and this is what that instrumentation looked like for Zimmer, and then within 2 or 3 years, many other companies came out with similar patient-specific instruments, all 3D printed, all taking basic software, three-dimensional software data, and putting it into an instrument that you then brought to the operating room, and that instrument became your ability to try to replicate what you planned at the time of surgery. And for all the surgeons in the room, you all know the limitations of that. It's not perfect, but it's better than eyeballing or, what some people call dead reckoning, guessing, saying, okay, I see the picture, I'm going to put the pin here, I'm going to move it in this direction. So it's better than that. And then there's this concept of adjustable instruments. They're not 3D printed. You can manipulate the instrument in a way that gives you the information, and that's done, it shows you here. So there are limitations, and these limitations are what spurred my current thinking and my latest activity, if you want to call it that, of developing something new that hopefully will be better. And that is the patient-specific instruments are based on pre-op plans. What happens if your anatomy at the time of surgery is not quite the same as your preoperative planning? What happens if you put the instrument in and it doesn't fit so properly, or you twist it in a certain way? There's some inherent error that is based on the basic technology. It's impossible to get around the basic premise that what I'm doing in the OR is based on information that I had before the surgery, and that I have to put this instrument precisely on the anatomy in order to reproduce what I did in the preoperative planning. So that got to this issue of saying after 15 years, we're at this plateau. We're at a point where we're not likely to get too much more juice out of the squeeze. I mean, I can squeeze as hard as I can squeeze. I am not going to get much value out of doing the same thing over and over. We have to think differently. So what's the next new platform? And this is my part of the presentation. This is the part where I am out, very far out on a limb, looking for some feedback. I talked to Bill Levine before the talk, and I said, Bill, I want your input. Not as a shoulder surgeon, but as a department chair and a manager of a hospital. So this is using intraoperative patient-specific instruments with a remote robot. So robots today, be they Da Vinci, be they Rosa, be they Mako, the robot is in the surgical field. It is physically present by the patient, and that robot is integrated into the digital field of the navigation. Okay, so that robot doesn't know what to do unless the navigation tells the robot what to, unless you're a Da Vinci, then the surgeon is moving the robot through his surgical navigation, through his brain. What happens if you take the robot and you don't put it in the surgical field? What happens if the only connection between the robot and the patient is the digital data? It goes from the surgical data, this navigation, to a robot. The robot manipulates an instrument that then is brought back to the surgical field. That was the event in 2021 in the pool. That's when I said, we can do this a different way. And I looked for all the prior art, I looked at all the patents, and I said, that's unique. And as a surgeon, I think that's clinically relevant. So, why is it potentially better? Potentially. Well, big robots are big, and they're very expensive. And, at least for shoulder surgeons, people are even questioning, do I need this amount of technology for execution of this type of surgery? Now, Da Vinci, different animal, okay? That's really a surgeon using micro precision, and when it's connected to AI and computer vision, it will be even more powerful than just a surgeon manipulating multiple arms. But for orthopedics, I think some people think this is overkill. It's a lot of technology, a lot of cost, maybe not enough value for that. So the new concept, as I said, is using surgical navigation for the purposes of information and decision-making and lowering the cost by virtue of having a very small format robot that manipulates a variety of instruments for the purposes of step 1, step 2, or step 3 in multiple surgical applications. So this would be adapted to any navigation system. It has the flexibility, and it's not contact-based. So the instrument doesn't have to touch the bone, so you don't have the errors of preoperative planning. You don't have the errors of the instrument actually having to contact the bone. And it's much, much lower cost. So 2001 was the concept. Patent was submitted in 2023. Patent was awarded in 2025. And the hard part was building a team to develop the product and to be able to figure out, will this actually work? So this is where we are in, what's today, December. So this is late November 2025. So this is the vision system. It has 2 stereoscopic cameras up at the very top. You can see the display. It's on a base that it's a telepresence robot. You can see it has 2 stereoscopic cameras in the top. In the center, there's a laser pointer that's robotically controlled, so it can actually point out things in the surgical field. This is the innovation. There's a small robot that you take off the back of the vision system, and this goes onto the back table, shrouded surgically, and the robot has 3 stations for instrumentation. The vision system digitizes without markers, without trackers, the anatomy. It does this in seconds, not minutes. You can find the center of rotation of the hip. You actually digitize both the tibia and the femur. You then put onto the knee, in this case, a instrument that becomes both the fiducial and the site of the application. This adjustable instrument is put on one of the 3 stations on the robot, and it has the ability, 6 degrees of freedom, to be moved in any position, and that is specified by the software, knowing where the plane of the distal cut needs to be for the distal femur. And once that's done, it's locked in place. It's moved from the robot on the back table to the surgical site. It locks in. You put in 2 guide pins. So if this were the glenoid, you'd put in 1 guide pin. You take off the instrumentation and you put on a standard cutting guide that comes out of the instrument set. The laser shows you where the pins should be, so you have a way of checking to be sure that the robot did what you wanted it to do, and then you make your cut. The vision system can tell that this cut is not even, show you where that cut needs to be fixed, and you can go back and finish that cut. So it has the capability of recut or repositioning, which again, 3D printed PSI cannot do. Here's a second instrument on a second site on the robot. It makes a precision adjustment, again based on the surgical decision making and the surgical navigation. This goes on to the 2 pins, which then lock in your rotation and your anterior-posterior femoral cuts and chamfer. Standard 4-in-1 guide goes on. So again, same instrumentation that's already existing in a knee set. And you put on your femoral trial. You do the same thing on the tibia after you do ligament balancing. This is what we're doing in validation for our accuracy. So this is a pre and post-op CT in cadaver knee. And then we can measure what you have in the actual cut. And this is the preoperative planned cut with a 3D printed cut, and you can see the accuracy. So where are we with this? Again, this is technology that's neither FDA approved. It's work in progress. And the reason I'm presenting it is because it's a good example of how you go from this 20-year effort of having a very persistent question of trying to improve the precision and the accuracy of surgery, and went from preoperative planning to patient-specific 3D printed tools to saying, how do we go to robotically assisted surgery and a much, much smaller footprint and much lower cost. The interesting part is that when you do computer navigation, it sees everything in the room. It sees the surgeon, the people, where they stand, where your hands move, what's in your hand, how the instruments move. All of that data over thousands and thousands of surgery become the basis for AI mentors, AI tools that can assist in a particular patient, in a particular surgery, if you know the algorithm to say, in this particular case, you might think about these options to balance this knee or to change your surgical direction. That's a much more difficult process, but it starts with having computer vision, computer navigation, and this sort of alternative robot. So in summary, the processes of research, development, innovation are these intertwined sort of iterative processes of data collection, data analysis, and this iterative process of thinking. Nobody is good enough to go from beginning to end. You have to build great teams, and that's what leaders really do. There is clearly value to coming to meetings like this. And my expectation is that people in this room will give me constructive and critical feedback, good or bad, and I will listen. Because I don't want to make a mistake and go down the wrong path. And I gave you a good example of that. Thank you very much. I think I've got time for a few questions. Yeah.
Thanks a lot, very inspiring lecture. How do you see the role of AI as invention or innovation in the next 5 years?
Yeah. Well, you know, I think I asked ChatGPT about 2 years ago about a remote robot. I wanted it to do a patent search for me to find out if I had something new or novel. It could not do that. Now, maybe it's because the algorithms weren't written for that purpose. I've otherwise asked other questions, and I think I've gotten a very thoughtful feedback about how to do things that I'm not that good at. So I think AI, which it's already done in many fields, I think in healthcare, other than billing, it's great for billing, it's great for data mining, it's great for large language models for dictation and creating a summary of your encounter. I think it's going to be really good in complex decision making, particularly for chronic diseases where there's clinical pathways, best drugs. So I think it's more on the innovation side. I think the invention side is probably the people that are already developed the technology. I mean, we're users of the technology. I think the people that really are the cutting edge are developing the algorithms. You know, the company that I'm working with, you know, that's our aspiration, is to have enough data from thousands of surgery to actually build the AI mentors. Now, I think, you know, I think that's going to be a heavy lift. I think we're going to get there. We got the right people, we got the right talent, but we have to be in hundreds of ORs collecting thousands of cases to actually have the data. That will be an invention, so to speak, not just an application, because we're creating something new that has not otherwise been created. Versus what you get now in ChatGPT or Gemini or any of these other, where it's really an application. The invention occurred 5 years ago, and now they're just releasing it. Great question. Bill.
So, it's something I think about an awful lot. Thanks. First of all, thank you for the talk. It's amazing. It's hard to encapsulate all that you've accomplished in a short period of time, but so thank you very much. I think about it all the time. We have a car that can drive itself, and then we bring in this monstrosity into the operating room in 2025 that looks like it's from Land of the Lost. Right? So clearly we are not where we need to be. But what I'm going to challenge you on, with machine learning and with all that's happening, I'm not sure you need hundreds of thousands of surgeries to get to the answer. I think you're going to have it way before that with combination of, my vision is that we never have to irradiate another patient again, so there'll be no preoperative CT scans, and that your device or one that I'm working on or someone else is working on will be able to use machine learning, look at the glenoid, understand the pathology that we're seeing, whether it's through an oculus or not, I don't know, and be able to find the exact center point and start to manage the patient's pathology based on the machine learning, based on.
I think that's true for the knee for sure, because either if you're doing kinematic balancing or mechanical axis balancing, you know the center of rotation of the hip, you know the femur. I think it's a little harder in the shoulder on the scapula side, not so much the humerus side, because you don't know where the scapula sits, relevant to what you see. Not to get into the details, I think conceptually you're right. I think if you had machine learning and the right algorithms, I do think you need thousands of cases, not hundreds of thousands of cases. You probably can do it with machine learning. I mean, that's the long-term goal of redefined surgery. Again, until I see it and we have a working prototype that actually is accurate, then like anything else, this is the self-doubt part of not thinking that you can do everything you say you can do. The robot's a done deal. I mean, we know it's accurate, it's precise, we can make it work. In a knee, we probably can make it work in a shoulder and hip. So that I know. Can we build algorithms for machine learning that you don't need a CT and you can have the machine learning tell you where to put the pin and the robot does it with you or for you? I've got to see. That's probably doable, but I don't, until I can touch it and feel it and see it. But it's good aspiration. Yeah.
One question, Joe. First, thank you for this great presentation. When I was a young surgeon in the 80s, we used to do a knee replacement with 10 instruments.
Yeah. I did it with 4 instruments because I'm older.
With the growing numbers of instruments and equipment
Yeah.
and innovation and devices, how are we going to deal in the future with the cost of surgery?
Yeah, I mean, I think that's the play of this whole thing. This is literally 10% of the cost. When you get away from infrared cameras and painting and all the instruments you need to register the body part, the cost goes way down. The hardware there, without the base robot, is about $15,000 or $20,000 cost of goods. The robot, probably at scale, is somewhere around $5,000 to $10,000, not $1 million. Now, will it do everything that a big box robot will do? No. It can only do certain things because it's a PSI. It's not a burr. The end effector is not a saw. It's not a burr. It can't do certain things that other robot can do. So this is the balancing act of trying to define which surgical cases are best suited for which technology, and is the cost valuable for the output, the outcome. I think with reusable patient-specific instruments, your instrument sets go down. With pre-op planning, you kind of know which implant you're going to use, 1 or 2 sizes, one size above, one size less, so you can decrease your inventory, especially if implants are being delivered, they're not in stock. So there are some plays here that this technology is not going to add cost. If we get the vision system to reproducibly do what takes minutes, seconds, then again, cost efficiency in the operating room goes down. So I don't think this particular robot is going to supplant the big robots. I think it's just going to take up a piece of the market where you're trying to really trim cost, improve efficiency, and do this in an outpatient surgical center.
Thank you for this nice talk. I have one question. When I start, I'm an interventional radiologist by training, and 25 years ago we developed with some friends some activity in neural navigation and brain navigation using CT and MRI. And 25 years after, it's still not used, not so much, except for a very mini-invasive radiation and biopsy.
Yeah.
Don't you think that all these computer and image-assisted surgery need to be associated with a much more mini-invasive approach and a very minimal incision and very limited surgical replaced by percutaneous
Yep.
navigation and intervention?
Yeah, I think that's one of the potential benefits of robotic surgery. Certainly, it's proved itself to be true for cardiovascular, cardiac surgery. I mean, the minimally invasive nature of valve repair has gone way down. Speed of recovery, post-op pain has become much, much better. So in certain applications, I think it does prove itself to have high value. for navigation robotics for certain applications. I think for this particular audience with orthopedics, we're in the very, very early stages of this. And, you know, my sense is that the technology we're developing might last 10 years. You know, will take probably another 4 years to become in the marketplace, and probably will last maybe 10 years, and then it will be replaced by something else. So, you know, nothing ever lasts much more than about 10 years. And I think it's that time is getting shorter because the evolution of innovation is just much faster than it was even 10 years ago. And that's this issue of timing. I mean, you have to have a good idea that's executable in a time frame where the technology is still relevant. If you take too long, somebody is going to eclipse you with something better. And that's how startup companies die before they get started. Yep, JD. Yeah, market size, and if you think about the exposure of a knee, it's wide open. You know, if you're trying to develop a new navigation trackerless, markerless system, you got to pick something that, so I picked what we did because it was the right decision to develop the company and the technology, not because I love knees, I love shoulders. You know, again, that's a practical decision to say, you know, how do you not fail in the first year or two? Because the laser is in the headpiece, and so the system knows where the laser is versus where the knee is, so it can shoot a laser, either a dot or a shape. So it confirms visually for the surgeon that the pins are in the right location. Because could be, you know, the problem with the glenoid is the exposure is very much smaller. It's darker, so you have to have the right lighting for stereoscopic RGB light cameras to actually get the right point cloud, to get the right 3D point cloud. So it's probably doable, but again, until you actually do it and prove it and make it work, you understand the challenges. But we picked the knee because it's a big market and people are struggling to buy $1 million robots for every room in the hospital. And even if they don't work, surgeons like them and patients like them. So there's still this motivation of how do we do it cheaper, less expensive, faster, which is, you know, the motivation. What's that? I couldn't hear you, JD.
Is the ultimate goal go to shoulder after the
Yeah, we're going to start prototyping some shoulders before the academy in March, but we're not going to have a product till we get the knee out in the market.
So this morning we spoke about the prosthesis, we spoke about how to think about the prosthesis, how to plan the prosthesis, how to reproduce, how to put it with the approach. Now let's turn to the results. And first part of the results is internal rotation. This is going to be my topic, short topic, and like this morning's, I hope long discussion. Some of my works, so I will be very happy to share it with you, and if you disagree, please tell it. This is the best way to improve, because it's not so frequent that the patient, they complain about their internal rotation after reverse. So what first you need to know that you need to wait, because we published with the Lederman that you improve your internal rotation after reverse shoulder arthroplasty up until 2 years. So if you have a patient 6 months or 1 year after surgery, your patients can still improve. Of course, it's not only because you want to recover
a part of your mobility. It is because it is important in your daily life. It has been published that the patient cannot really well tolerating if they don't recover their internal rotation, which is very, very important. Second, which is very interesting, we call it, we spent some time this morning to try to find the good word for the good thing. Probably we should not call it internal rotation, because it's not really an internal rotation. In fact, it's a kind of adduction, extension, and elbow flexion. So it's a combined movement. We prefer to call it, I prefer to call it end behind the back rather than internal rotation, because you have a lot of possibility to measure your internal rotation, but it's not really what is important. We think that the important thing is to be able to put your hand behind the back. So we define three types, type 1, type 2, and type 3. Type 1 is a failure. It's a failure because the patient complained. They said, "Doctor, I'm sorry, but it's difficult for me in my daily life, especially if you have two rivers. It can be very, very difficult." So type 2, as you can see here, is not a normal internal rotation. The patient needs to crawl a bit like that. But for the lady, they are able to reach the bra, which is the most important. And of course, you can have a normal internal rotation, which is not so frequent. So in all our studies, in everything that we've done, we've grouped the type 2 and 3 in functional internal rotation, and the type 1 in non-functional internal rotation. So we've tried to look at the implant, and we'll look at the glenosphere to try. I thought at the beginning that it was logical, if you have a large sphere, you will have more motion in your sphere and a better internal rotation. So we tried to look at this, and then there was a lot of patients, more than 300 patients, same surgeon, everything the same. And then there was absolutely no difference in terms of size of the sphere. Whatever the size of the sphere, for this series, there was no difference. It was only flex only, 155, 45. So after that, because I had in my database other patients with the Grammont design, so we tried to compare neck shaft angle, 155 and flex 145. I haven't not checked yet the Franco design, and there was a lot of patients, almost 400 patients, and there was no difference whatever was the neck shaft angle in the recovery of the internal rotation. So for the size of the implant, for the neck shaft angle, at least in my patient, on more than almost 400 patients, same surgeon, there was no difference in terms of rotation. I have to precise that for me it's always 20 degrees of internal rotation for the humeral side, and all the data in the literature show that you cannot modify your internal rotation by modify the internal rotation of your humeral implant, so humeral implant. So regarding the patient, and we have had this discussion this morning about the recovery of internal rotation. We've published that 1 year ago with one of my fellows, and we've compared from primary osteoarthritis, massive cuff tear, and cuff tear arthropathy in order to look at the internal rotation after these different etiologies. And you can look at the results. This is very interesting. If you have an osteoarthritis with a good cuff, then you may, this is non-functional, this is functional. Then you may, this is pre-op, this is post-op. It means that if you have an osteoarthritis with a good cuff, you can set your, at least with this series, you can explain to your patient that he has a good chance to recover the internal rotation. If it's cuff tear arthropathy, he has some chance to lose internal rotation. And if it's massive tear, a higher chance to lose internal rotation. Then about that, that's why after this study, we thought that it's probably related to the subscapularis. So we'll look at the subscapularis precisely. And we've included 100 patients. And same prosthesis, same design, same etiologies. First very interesting thing, which could be related to the subscap sparing. I was very surprised. It was Grammont design, but I was very surprised to see that in one case out of two, I was unable to have a healed subscap after my reverse. And you can see that if you look at the question was, do you have a better internal rotation when you have a healed subscap compared to non-healed subscap? If you look at the global constant score, there is no difference. But I think that you should not look at this because frequently in the literature, it's reported with a SES score or another score or constant score, but you need to focus on the score, on the part of the score which is mainly related to the internal rotation. If you look at this on the constant score, it was significant, 5 compared to 7. So you can see here, without subscap, with subscap, you have clearly a better internal rotation when you have a good subscap after a reverse. But it's not only, because sometimes, as you can see here, you can see that you have no subscap and you have a good internal rotation. So it means that there are probably other parameters. So we've looked at other parameters and we published it. And this is one parameter. We've looked at the internal rotation in position 2, like this. Anyway, so you do this and you look passive internal rotation in position 2, like this, and it was clearly related. When you have a good passive internal rotation in position 2, most of the time you have good active internal rotation in position like that. And we've looked at the scapular tilt. As you can see here, you can measure your scapular tilt with this device. And for the scapular tilt, it was not significant. Isolatedly, it's not significant. Whatever the scapular tilt, there is no really correlation with the recovery of internal rotation. But if you look at the patient with a very bad passive internal rotation in position 2, like that, when they are stiff in position 2, then the scapulothoracic motion is very, very important. If you work on your scapulothoracic, and then you can improve your internal rotation when you are a bit stiff here. And we've done a multi-parameter analysis, and you can see that it was clearly correlated with a good p-value, especially for passive internal rotation. And you have here all the data, and the most important remains the subscap. So for inlay no, for shear size no, for etiologies yes, for subscapularis yes, passive internal rotation in position 2 yes, scapular tilt yes and no, depend if you are stiff in position 2 or not. So take-home message, I definitely think that we need to reattach the subscap, or as Arno said this morning, don't detach it. You will have 100% chance of healing. And then what we could do is, if you look at, if you have one patient at 1 year, or 2 years, the patient is complaining about the lack of internal rotation in position, a lack of internal rotation. Look at the internal rotation in position 2 like that. If you have more than 50, it's probably a problem of rehabilitation, you will recover. If you have less than 50 degrees, then check your subscap. If your subscap is healed, if your subscap is not healed, probably the patient will never recover the internal rotation. If the subscap is healed, you can work on the scapulothoracic motion, and we've published that with Lederman. You can do that. The physio does that. Here you have the video. I'm sorry. Anyway, there are some exercises like this that the patient can learn in order to try to get into the scapulothoracic motion what you have been unable to have in your prosthesis. Thank you.
Okay, we're going to be talking about how to recover external rotation after reverse, and I'm going to be giving the American perspective, as we said. In general, this is probably less important than internal rotation, because as opposed to internal rotation, you can just do this if you can't put the arm up to the side, except in some circumstances. Next slide. So
Shouldn't you really be saying you're giving the Canadian perspective?
next slide.
Thank you.
Next slide.
Yes.
No. Yes. So I was a little bit confused when I was asked to to give the American perspective. One, just because I'm Canadian, yes, this is Vancouver, my hometown. So hopefully next year I'll be seeing you guys at the International Congress there. We'll have some fun. But more so than that, I thought traditionally the American perspective was that the tendon transfers don't matter. So I did a little sort of random sampling of some surgeons around Boston just to see what people thought. So these are from Andy Jawa, Gus Mazaka, and a few other people. And so their answers were, no, you don't need that with a lateralized implant. No, you get osteolysis around the stem. No, there's a higher chance of dislocation. And no, I don't think it does anything, and it's just a tenodesis. So if we move on, these are sort of my indications for a reverse with a latissimus dorsi tendon transfer. So we're talking about the ER1 and ER2 position. If you have a significant lag with no presence of a teres minor, you will not get that back after a reverse of any prosthesis, lateralized or not. These are the patients who will be able to lift up their arm and they'll have to do this to get their hand behind their head. Next slide, which is, again, depending on the question that you're asking, what you're looking at, which Dr. Iannotti has been talking about, their patient-reported outcome measures will reflect that they're happy. But when we talk about the studies, which we'll go through later, these patients, in a high percentage, are not able to actually get their hand behind their head. So, similarly, if they do not have a functional teres minor, they'll be able to get to probably neutral and hold it, and then they'll cheat with their scapula and get to 30 degrees. So if you look at the outcomes of these studies, without this, for clear patients, massive rotator cuff tears with combined loss of elevation, external rotation, those patients can't functionally get more than that. Next slide. This is a video. So this is a patient that I saw, if you click on her. A year after a dislocation with a massive cuff tear and a recovered brachial plexopathy that was sent over to me. So she's got a big lag in ER, and she's got that classic hornblower sign where she's not able to do it. She's very active, though she is older. She takes care of herself. She's very active in the community. So we'll see what happens with her at the end. When we're talking about shoulder motion after reverse, you can play this video. This is another 4D CT scan of a patient with performing abduction after a reverse. So the amount of abduction that actually comes from the implant is maybe about 60 or 70 degrees, and it's combined scapulothoracic. So we have to understand that we position the scapula in retraction predominantly in external rotation. And depending on the type of implant that we're using, the teres minor is really the most important component. The posterior deltoid, which attaches 5 or 6 centimeters from the medial border of the scapula, if you put your arm up into this position, you try to externally rotate, you feel your posterior deltoid, it's not going to do anything. It's predominantly helpful in abduction and extension of the shoulder. So the vector just doesn't make sense. Next slide. And so biomechanically, when we're talking about this, Gerber's group, using a distalized Grammont-style design, said that there is no way that the posterior deltoid can take over for the lack of a teres minor. If you are performing a latissimus dorsi transfer, it has a 7-fold lower force required for external rotation than a teres minor if you put it in the right spot. And that right spot is at the teres minor insertion. This is for both distalized and lateralized implant design. So it actually increases the torque by 67%, and it shares the load and reduces the deltoid force necessary in these patients. And studies that have used electromyography over time have shown that it actually becomes an external rotator and an abductor. It becomes an agonist in follow-up. And in this one study showing that both the lag and hornblower signs were negative and it had adapted function compared to the contralateral side. Now, regarding complications, this is a nice systematic review with Dr. Werthel involved. And similarly, the biggest concern of complications is that of instability. But we have to remember that the patients who are getting this are likely probably pseudoparalytic to begin with. They have massive cuff tears and they are the highest risk of dislocation inherently anyways. And in this systematic review, their 3.1% instability was very similar to our combined complications of reverse shoulder arthroplasty study group with over 7,000 patients, which was around 2.1%. We see here, though, that for patients with these massive cuff tears, that there is, if you only look at that one subset of people, they have a very high rate of dislocation in general. Of note, yes, there was 30% humeral erosion, but likely that is not the case of causing any concern unless you're doing a revision and the stem is very big. Next slide. We're looking at clinical outcomes, variable reporting, variable quality of studies looking at this. So in the pro camp, Louis Shee, JP Warner's group, looking at improvements in ER1 and ER2 position from a medialized implant latissimus dorsi. The wider study group didn't look at repairing any subscap. They didn't look at any different. There was no difference in patient-reported outcome measures, but none of them commented on this hornblower or ER lag sign. This was a nice RCT done by Young et al. Showing that the presence of this actually significantly improved that ability to put the hand behind the head. And this one, Berglund et al., looked at 33 patients, 24 in the combined loss of elevation external rotation group versus 9 in the non. And for the patients in the clear group, without a tendon transfer and purely a lateralized implant, a third of those patients couldn't reach the top of their head. And they also had lack of elevation greater than 90 degrees as well. So in those circumstances, I think patients would not typically be happy. And so I think also the technique really matters. And this also speaks to the fact of it potentially being a tenodesis versus an active effect. And so here I work below and above the pectoralis major. You make sure that you get rid of all the adhesions to the teres major below it, as well as the triceps and the pec. We pass it around behind, and then we affix it up by the teres minor footprint. And this is with a lateralized design. This is my American perspective. I use buttons, but you can use drill tunnels. This is just more expensive. Next one. So this is our 2-year post-operative of our 88-year-old, I guess now she's 90-year-old female. She's a spry 90. You can see some osteolysis on the stem, but she's able to touch the back of her head, and she has good motion in all planes, and she's quite happy. But still only 90%. She does not have the strength to lift the arm up. So these massive cuff tear people, regardless of whether they have good motion or not, those people still do not like the strength of their shoulder. Next one. So in general, I think that this is predominantly indicated for anyone with an ER leg and ER1 or ER2 position without a functional teres minor. I think this is biomechanically favorable. The transfer actually does turn into an external rotator, and the technique matters when you're doing this.
In fact, it's not the French point of view, but the point of view of PubMed, but maybe with a French point of view. And I will show you why, at the light of the data we can find on PubMed, that to recover a good external rotation after reverse, lat dorsal transfers is not necessary in most of the cases.
By the way, it's really French and American. There's the Eiffel Tower and the American flag.
Exactly.
I'm happy. That's exactly what we want.
Exactly. So background, we know it. Reverse can help us to get a good active elevation, especially when we have a massive cuff tear. But in this case of patient without posterior cuff, the recovery of its rotation can be difficult. Especially with the Grumman type prosthesis, we will show that later. So 2 main strategies are available to get a good recovery of external rotation after reverse. Either you can try to optimize implant design and positioning, or you can try to combine your reverse with a tendon transfer. And amongst all these parameters that we can play on and change, finally tendon transfer is only one of these parameters. So all these parameters can be optimized without doing any tendon transfer. So what are the respective roles of these different determinants of external rotation after reverse? When we look at the literature, we can see that the old design, the Grumman design, wasn't a good design to get a good rotation, either external or internal, because it leads to an early impingement between the humeral implant and the scapular pillar. So it linked to impingement. So how to say, with the next, the new design implant, it provides a better range of motion without any impingement in rotation. If you use a humeral lateralization and a more vertical neck shaft angle, it can help also to change deltoid and posterior cuff moment arm and helping us to get a better recovery of external rotation. When we look at the glenoid lateralization, we can see that it, like the other parameters, it helps us to improve overall rotational envelope, especially internal rotation. And we can also try to do something here to optimize the external rotation recovery. What about the glenosphere size? It helps also to get a better recovery of external rotation. It's modest, but it helps. And when we look at the version, we should be aware of if you try to do more internal or external rotation on the version, it will maybe help us to get a better external rotation, but it will have an impact on internal rotation, and the opposite is on the right. What about the soft tissue? Posterior cuff. For sure, posterior cuff is very important to get a good recovery of external rotation. We know it because of a few publications, but if you use some kind of modern implant reverse, this external rotation is no longer only teres minor dependent, and the posterior deltoid role play a major role to get a good recovery of external rotation. What about the subscap? For sure, subscap is not a lever for external rotation recovery, but we shouldn't overtake too much subscap if you reattach it, because it will probably lead to a loss of external rotation in this patient. So what are the role of tendon transfer combined with a reverse shoulder arthroplasty? Tendon transfer has been used since a long time to get a better, to get a recovery of external rotation in patients with a posterior supra cuff tear, because it helps us to correct this horizontal imbalance by turning these two internal rotators into two posterior rotators. So it's logical in patients with a true clear without any infraspinatus and without any teres minor. Well, what about the result? The result of this tendon transfer, so like dorsal and teres major, it helped us to get a significant improvement in PROMs, in external rotation, but at the cost of a high complication rate and a significant loss of internal rotation. We have to be aware of that. It improves external rotation, but higher complication and reduced internal rotation. So what about doing a lat dorsal transfer without teres major transfer? It seems that with this option, a patient will recover probably the same outcome in external rotation, but it helps us to preserve the internal rotation force. Well, this is two studies comparing lat dorsal versus lat dorsal with teres major transfer. As I said, similar gain of external rotation, quite the same for Kensen score, but lower complication rate with isolated lat dorsal transfer, and probably so better range of motion. So if you choose to do a transfer, probably an isolated lat dorsal may be preferable than doing lat dorsal plus teres major. Okay, so it worked, but what about comparing tendon transfer with RSA versus RSA alone? So different study that compare both, and what did they find? No difference in the first study between two groups at 2 years for scores, especially also range of motion. Second study, no significant advantage of doing a lat dorsal transfer on external rotation, it's interesting, and pro also. Internal rotation slightly better in the patient, in the group of patient without any tendon transfer, and last study, better external rotation, worse internal and more complications. So it seems that doing a tendon transfer with an RSA over the patient with an RSA alone is probably really slow, but morbidity and loss of internal rotation is clearly higher in this patient. So to conclude the French point of view, if we can say, what can we do without tendon transfer, so only with the implant design, and what only tendon transfer can achieve when speaking about external rotation? So with the modern kind of implant, so lateralized or semi-inlay with a vertical neck shaft angle, lateralization on the glenoid side or on the humerus side. When we look at PubMed, we see that most of the patients recover a good external rotation, good clinical score, especially in patients with preserved teres minor and with a preserved posterior deltoid. And in this patient, we see that external rotation recovery depend most on implant design and positioning than on doing a tendon transfer. So in my practice is almost all of the cases. But I must say, I agree that in some case doing a tendon transfer remain a valid solution in patient with a true clear, so massive cuff arthroplasty without any posterior cuff, any teres minor, with a positive on blower sign and complete lag sign as you shown on your patient, or with patients that need a strong external rotation, something that we can find on PubMed. I don't know what is a need of a strong external rotation, but in my practice is less than 10% of the cases. And in this patient, we have to know that this comes with a higher complication rate and a systematic sacrifice of internal rotation power, especially if you do lat dorsal plus teres major. Thanks a lot.
So bone loss usually in primary is surface bone loss, not cavitary bone loss. It could either be anterior, posterior, mostly anterior from trauma, posterior from osteoarthritis and superior and cuff tear arthropathy. Central bone loss typically is from inflammatory arthritis, where you get fairly uniform wear. And then, as I said earlier, cavitary bone loss with or without wall deficiency, meaning contained or uncontained, is typically in revision. And global bone loss, which we see on occasion, is usually multiple causes, trauma, revision, infection. So this is typically the classification we use for osteoarthritis from Gill's original work, more recently modified in 2016 with the identification of the B3. And we know from some natural history studies that you start with a B, the head translates posteriorly, and then you get this progressive wear, and the biconcave glenoid with persistent medialization, the head begins to recenter a bit, and you've got now a B3 monocave deformity. And then with superior migration of the head in cuff deficient shoulder, you get varying degrees of central and superior bone loss. So the problems associated with bone loss, and you can treat this without a wedge, without a bone graft, but typically you're putting the base plate in either superior tilt, which you obviously want to avoid, or more retroversion, which can result in malposition, impingement, sometimes instability, a loss of motion. So there is a rationale for trying to correct the bone loss with either a wedge or bone graft. And, I think it's personal preference. Typically, wedges are easier to put in. You don't have to craft carve the defect or create a defect that matches the bone graft. You don't have to worry so much about bone incorporation or fixation. So there's been a greater tendency towards movement from primary bone graft, which is, in my personal preference, that's what I would prefer to do, but certainly most people use some kind of wedge. So when you use a wedge, typically it's going to be a modular component, because unless you can use a central peg where you can rotate the wedge to the right location, but if you're using a central screw, then typically it's going to be a modular component with some kind of central post or boss with a compression screw in the center, and then some kind of peripheral screws. And again, standard base plate, small amount of bone loss. You could easily ream a bit on the glenoid side, the high side, and put in a standard glenoid component. And then most systems have a fair amount of availability of different head sizes, lateral offsets, which again help you compensate by getting the lateral aspect of the glenosphere in the right location. So many companies have lots of different variations, either half wedges, full wedges. I think with bone incorporation, meaning some kind of porous surface, some of the worries that some people have with anatomic augmentation with a full wedge is probably less important in a reverse arthroplasty, where you've got a solid fixation, porous in growth, and the like. We talked about lots of variations. You can see the commonality is modularity, central boss, porous in growth, and either full wedge or half wedge, depending on which company you're looking at. So again, preoperative planning is useful. You can see that in this particular patient, there's superior bone loss and cuff tear arthropathy, and the planning is to put the central peg in the center of the glenoid. You're going to ream the inferior part a little bit so you have some contact between the base plate and the native bone, and then you're going to fill in the area where you can see the pink with this statistical shape modeling, either a wedge or a bone graft. It's your choice. It's primary, so the bone graft is easy to get from the humeral head. And in this case, we're looking at a a significant defect more than this particular wedge. Now, again, perfectly fine. You just ream it a little bit more, and you're going to maybe use a little bit more of a lateral offset on your glenosphere, and you're back in the same place. You know, ideally, you like to get, I like to get the lateral-most aspect of the glenosphere about the middle of the acromion. That's about where you should end up. Now you can get there with bone graft, you can get there with a wedge, you can get there with a more of a lateral offset glenosphere. And I'm not sure that there's any data to support one being better than the other. So in this case, this was an augmented glenoid. This particular design has different size central screws. You can either use a 6.5 or an 8.0. Again, for some poor bone quality, revision arthroplasty, you might go with the 8.0 screw. It comes in 2 lengths so that you try to get bicortical fixation if you really need a longer screw. And this happens to be a flush mount or inset humeral component. This one is a little bit more bone loss. You can see this one is bone grafted. And you can use, in certain types of glenospheres, you can use this sort of small hood that comes in the glenosphere, and that if you position that on the bone graft, you're loading the construct both through the boss and the screw, but also you're contacting the glenosphere onto the bone. It gives you a little bit more stability. Again, probably not critically important in a primary, but you get good fixation. But this becomes more important when you're dealing with revision, cavitary bone loss, and you're trying to get more fixation by contact of the glenosphere onto the bone graft or the native bone. So again, you can see that in this particular company, there's a very wide variation in offset, radius of curvature, and this sort of hooded design. And again, most of us who use this system use the hood for the purposes of contacting the glenosphere onto either the native bone or the bone graft. And it comes in lots of different offsets. So here again, this is a D glenoid. So more anterior, you can see this case here with the use of bone graft and using the base plate to both contact the native bone as well as the graft, and the hooded design of the glenosphere to contact the graft, and you can again see the post. And this is that deep glenoid edge anteriorly. For more severe bone loss, there is this sort of semi-custom design that Stryker has. They call it Shoulder ID. You can go up to 17 millimeters of graft. I think this was very recently FDA approved because they have sort of the biomechanics and the basic parameters to say, oh yes, this is a custom for this patient, but it's within this range, and the mechanics and the design are similar from case to case, so it's not truly custom, but it's customized for the patient. And this can go up to 17 millimeter of bone loss. And you can see again, similar, this is a post, but a very similar design relevant to the porous ingrowth. And this is an example case, very severe B3. Again, in my practice, I would have typically reamed up to here and got 40–50% of backside contact with the base plate and put in a bone graft. Did many of those, and they work fine. Again, you have to get the right length screw and good screw fixation, but they incorporate well. In this case, this patient, this was planned with blueprint. You can see the severe bone loss and planned with a wedge component, and this had a guide for the center pin, and then a guide, PSI guide, and you can see the base plate placed in and a good post-operative recovery. This is not my case. This is the heat. Did this relatively recently. So in summary, there's lots of ways to deal with bone loss, either anterior, posterior, superior. Current trend is towards wedges of some sort. They're easy to do. They seem to incorporate well. The fixation is excellent. And you don't have the complexity of trying to get the right size fit bone graft and get good fixation. So I think that this is where the trend is going. And I think that's it.
So how to deal with dislocation of RSAs is a really hot topic because sometimes nothing works. And if you look at the data, we can see that after primary reverse, we've got like between 1 and 2% of dislocation. But if you look at some specific indication like revision, you've got 20%, and if you've got a massive resection for tumor, it's like 50%. In a large cohort study with more than 6,000 reverse, the American Shoulder reported 2.1%. But if you compare to hip reconstruction, total hip, it's too much because total hip 0.5 to 0.6%. So it means that we are not good regarding dislocation with the reverse. There is probably many reasons, many technical factors that can increase the risk of dislocation. The first one would be previous surgery, and it will increase the risk by 3 regarding the literature. Deltopectoral approach will be higher at risk than superolateral approach. They can have some cam effect if you use a reverse for humeral deformity, or because there is some ossification around along the glenoid. They can have some soft tissue deficiency or humeral glenoid bone loss. It means bone deficiency as well. If we look at this classification system from Mark Frankel, you can see there is 3 categories. The first one would be a loss of compression. So the second one would be a loss of containment, and the last one would be a problem of impingement. And if you look at inside each category, you will find that there is some reason related to soft tissue deficiency, the deltoid first, but the subscap as well. And some others are related to the bone, the humeral height loss, it means a shortening of the humerus, or some fracture around the reverse, like acromioscapular fracture. And the last one are related to the device itself for part if you look at these different reasons. So there is 2 categories of dislocation. The early dislocation, we can say that it's less than 3 months after the surgery. And obviously 100% of you will try to reduce under general anesthesia with a close reduction, and you will get a success in between regarding literature between 30 and 50%, and you are happy if you get that. But sometimes you don't get. You need to revive the patients. But if you get the good reduction, you will unfortunately be at risk of a new dislocation in about 40%. So after early dislocation, you are not sure to be succeed at long over time. And sometimes, like I'm doing right now, I always reduce the patient and test the patient like we could do for elbow, for example, or another shoulder cases of dislocation. And you can see that there is some anterior dislocation, but sometimes lateral dislocation, as you can see here. So the patient is able to dislocate laterally, anteriorly, but not posteriorly. As you can see, it's stable in posterior directions. So there is different probably kind of dislocation. Most of the time it's anterior superior and rarely posterior, as you can see here. But under general anesthesia, you can feel if the shoulder will be stable over time or not and to be honest, this patient dislocated another time. If you got a late dislocation, or if you fail to reduce the patient closely, you need to analyze what is the cause of dislocation. Sometimes you don't have any, but sometimes you can find, as you can see here, humeral lengthening, which is a shortening of the humerus, just because you don't put the stem at the right level, as you can see on the right hand side, because you cut much more than you should on the humeral side, just because, for example, you don't have any good exposure, so you decide to cut much more of the humerus to have a good view on the glenoid, and it's really a mistake at the end. And the other reason is just because you have a subsidence of the humeral stem because of loosening. But in both situations, there is probably a decreasing of deltoid compression forces that can explain what happened. It means a dislocation. This is just a specific case. You can see that there is a very bad proximal humeral fracture with an extension in the diaphysis, in the shaft, and the surgeon reconstruct around the epiphysis around a reverse with a long stem, but unfortunately you don't have the good landmarks and probably shortened the humerus. That's why it had the dislocation. They need to add like a spacer just to increase the length of the humerus, and hopefully it don't have any other dislocations. The other issue that you can check is that you have a proximal humeral bone defect, just because you have a greater or lesser tuberous lysis, or just because we don't reconstruct carefully your proximal humerus in case of revision. And in both situations, there is like a decreasing of deltoid wrapping forces that can compress the humerus onto the glenoid. This is an example here with a bad proximal humeral fracture with treated with a reverse, as you can see, but the patient are clear osteolysis of greater tuberosity, and you can see that the surgeon had a dislocation and probably a loosening of the stem as well. And the last question is what's the problem on the glenoid side, on the glenosphere? And if you look at this picture, you can see that if you medialize the center of rotation, probably that you will increase the lateral slope of dislocation of the humerus. So probably that too much medialization of the humerus is at risk to have reverse dislocation and a recurrence of shoulder dislocations. So there is probably many reasons, and this algorithm was proposed by Pascal in 2016, and he said that if you have a humeral shortening which is less than 15 millimeters, probably that you will use a thicker polyethylene or metal spacer just to compensate this shortening. But if you have too much, you have to revise the humeral implants and to put probably a humeral bone allograft to reconstruct the proximal humerus. If you have too much medialization of the humerus with a shortening of less than 15 millimeters, probably that you could use a larger glenosphere just to over-lateralize the humerus. And if you have too much, it means like more than 15 millimeters, probably that you have to revive the glenoid and to use a larger or more lateralized glenosphere, or to revive the base plate and lateralize with a bone graft, because it was the trends at this moment. With my friends, we have another option, and especially because if you look at what happens regarding the different system, we are using much more lateralized implants. You can see here what was the Grammont style and what we are going right now with lateralization that you can get in the stem with more vertical neck shaft angle, and because you've got much more lateralization in the glenoid side as well. So you can use some laterals or high laterals or very high lateralized reverse. And we know that even if we lateralize the implant with the neck shaft angle, which is more vertical, according to us, you are always at risk to have much more instability. And we have our experience that we extract from this study, which is a multi-center study in which we included all the same implant with 145 degrees, with primary cases with a problem of instability, and then we revise with a more horizontal neck shaft angle 155, which is really unusual. So we collected 9 cases which were unstable that we revised first with just changing some sphere or glenoid or thicker poly, but in which we had a recurrent instability. That's why we revised the stem. So this is a cohort, nothing special. Report that some rivers were indicated for fracture sequela or failure of rotator cuff repair. And we have a number of instability, as you can see, from 2 to 20 recurrent dislocations. And it was most of the time the patient we are in the first month after the surgery. Some dislocated because they lift very heavy stuff. Some also just because they get up from the chair, and some others we don't know exactly how they dislocated. All the patients were first revised with partial revision. It means that we change the sphere to a bigger one. We increase the thicker of the poly, but we didn't succeed at this time. And we decided to change the neck shaft angle. And this one of my cases, you can see that is unstable. It's not a full dislocation, but it's the subluxation, which is much more lateral than anterior, as you can see. And it was like all the 9 cases, 145 inlay or only system with retroversion of 20 degrees. And we decided so to change for another system because we don't have another poly or another system we can switch to 155. So we use a Equalis system or an extend stem, and we put between 0 and 20 degrees of retroversion, so less retroverted stem. So we analyze the results, but it's not interesting here. The outcomes were really good, of course, but I want just to show you that at mean follow-up more than 2 years, we didn't have any recurrences of dislocations. So it's really surprising and for us, but we succeed to stabilize the patients. And we looked at just the parameter on X-rays in post-op regarding lateralization and distalization. We thought that we distalize and medialize the patient, but regarding the data on plain X-rays, we didn't get that so much without any significant difference. We just lateralize just a little bit more, but it's not a lot, and we distalize not at all regarding when we change the stem. But what we change probably is the capture of the poly. If you look at the primary surgery, we look at regarding the diameter of the sphere, you've got a percentage of capture of the poly which is decreasing. And much of the time, the first revision was just to increase the size of the sphere, so we decrease the capture of the poly when we do the first surgery. And when we change the stem, we change the neck shaft angle for sure, but we change also the percentage of the capture of the poly regarding the 2 stems that we use. So probably that there is an action there is probably a factor when you change the stem, there is a percentage of capture which is depending on the system you use, and nobody knows that, but it can be really different regarding the different systems. And the other thing we did, and it was like we tried, so we don't know how to do, but we said, well, maybe there is too much retroversion, so we put in 5 cases neutral, and it was minus 20 degrees, and we put the stem in neutral position, and probably that we had an impact of stabilization. And this is another example which is not included in the series, but it's another one. The surgeon did a mistake. Probably it's not the better X-rays than you can get, but he put 75 degrees of retroversions and on the stem, which, yes, this is too much for sure. So this patient was revised, as you can see here. This intraoperative just testing, and you can see that it's really, really unstable. And we just put 0 with I don't know how the surgeon did that, but that's what we found during the surgery. And we put just 0. We increase the size of the length of the humerus, and we use 155 neck shaft angle, and it was stable over time. I would share with you that our experience to switching from 145 to 155, which is Grammont design, was efficient in this series. We don't know exactly what was the main factor we stabilize the reverse. Probably that we put the stem much under our lateralized glenosphere, because the primary glenosphere is lateralized of between 5 and 6 millimeters, depending on the size of the sphere. But we had probably an action on the poly, which is more retentive than we have in our portfolio. Just to conclude that dislocation is rare, but worrisome complications. Most of the time it will recur in our experience, and it's needed to revise the patient. There is like a checklist, probably when we are facing an instability, humeral length, soft or bone tissue deficiency, and probably that we can just check how the percentage of capture you will use in the new system when you revise the stem. And sometimes, while you throw in the towers and you go back to LME, and probably it's not the best result, but we can get some. Thank you for your attention.
So we're going to talk now about infections. Infection for a surgeon is one of the 2 nightmares. The second one being income tax, of course. But it's always a big problem, especially in orthopedic surgery, where infection is a catastrophe. And when you see the digestive surgeon, they reoperate the patient with infection, they look without, not bothering. It's not the same for us. Of course, because of the augmentation of the prevalence of shoulder arthroplasty, infection also is going up. We think that in France in 2024 we don't have the results, but probably there was about 25,000 to 30,000 shoulder replacements, and it's going to go up more than 200% every year. So it's a huge augmentation, and on primary surgery, this infection is about 1 to 6%, depending on the articles, and on the revision even more, 4 to 15%. It costs a lot of money. In France, we have a big problem of cost of health, so it's a huge problem. It costs lots of money for the patient in France, because sometimes they pay the surgery, for the system, for the hospital. And of course, the complication of the surgery is much higher than the rate of complications is much higher than other surgeries. We started in the beginning to use exactly the same procedure and the same pattern that we use for the hip replacement, but as you know, of course, the upper extremity is not the lower extremity, so over the years we looked and changed the techniques and the indication. On the last meeting about infection, about periprosthetic joint infection, we separated 4 categories: real infection, definite infection, the one you're sure of, probable infection, possible infection, and unlikely infection. Definite infection, you've all seen these cases, and when you have a sinus tract with pus going out from the sinus, when you have imaging showing a purulence inside the joint, or when you have 2 positive culture with identical organism. The problem with this is very often we are reluctant in doing the diagnosis of infection, because you don't want it to happen. So you see the patient at the consultation, is a bit red, the sinus is coming, that you're reluctant in doing the diagnosis, so you don't want to look, so you see the patient the next week, and at one time, you get the diagnosis that this is infection. And it's a big problem in France in terms of legal issues, because when you're sued for an infection, very often you're not sued for the infection, but for the delay between the first time you saw the patient with some signs and the diagnosis of infection. So that's a very big issue, because as surgeons we are like in pain for an infection. So we don't want it to happen, so we don't want to see it also. Then there is the magic number 6, so probable infection. You got the minor criteria, you got the list here, you got some blood examination like ESR and CRP, inflammation signs, a positive culture. Well, all those minor criteria, if you have 6 of them with an organism that you find, that's a probable infection. They're going to treat it exactly like an infection. It's possible when it's 6 without finding of an organism, but you've all done some surgery on infection without finding any germs. Probably sometimes because the patient had antibiotics before, and as you know, the germ we're going to talk about is very difficult to identify. And unlikely when there is less than 6, no culture, and nothing among those minor criteria. Risk factor for the infection on shoulder, it's quite similar to hip, but difference on germs, and male have more infection than women. Younger patients have more infection than older patients, as you can see, age inferior to 65. Of course, when it's a revision surgery, there's more risk. Operative time, for me, that's one of the most important things. When you see, that's the problem of teaching and learning curve. When you do a surgery with putting an implant and it lasts 3 or 4 hours, of course, there's a very big risk of infection. Having an open wound next to the ceiling, of course, that's not the best thing. So operative time is, for me, one of the most important factor of infection. The weight of the patients, very, very fat patient or also very thin patient, there's a bigger risk of infection. Comorbidity, of course, like corticosteroid, autoimmune disease, some cancer, and tobacco history. Well, among all factors, it's one of the most common in all orthopedic surgery. The more common enemy, the more common germ is the Cutibacterium acnes. It was formerly known as, it's like Prince, formerly known as Prince, formerly known as Propionibacterium acnes. It's a gram-positive bacilli who stand on the skin of every one of us, probably, especially in the axillary area. It's found in the pilosebaceous follicles. There is some thinking about these follicles maybe communicating with the joint, and some people think that it could be inside the joint even before the surgery, because the distance between those follicles and the joint, because the joint having the distal part of the joint is very low and it's very close to those follicles. So there could be a communication between the follicles and the joint. It's very difficult to make the diagnosis because you have to hold it for a few weeks in special medium. And it's, as you see, the common germ. The other one are also some not very virulent germ, like the, you see, okay, I can see, well, Staphylococcus epidermidis, coagulase negative staphylococcus, and very rarely very bad germs like the one you found in the lower limb because of the proximity of the digestive tube. So there's going to be a debate afterwards, because as you can see, I'm going to show some literature showing that single stage revision has better outcome than 2-stage revision. But at the end, I'm going to tell you that we do with Philippe 2-stage revision almost always. So there's going to be a discussion. So single stage revision with or without changing of the components or changing of just the modular components. It's 2-stage revision, which is our favorite treatment with Simon spacer and antibiotic in between. Multi-stage revision with some, we have no experience of this, but with some microbiological examination every month and doing multiple stage. And salvage procedure, which could be a resection arthroplasty, which is very bad for the shoulder, and also permanent antibiotic spacer when you cannot do the second stage. How do you decide? one of the most important things for us is the delay between surgery and between the surgery and the diagnosis, the medical status of the patient, the age of the patient, the risk profile, what the patient wants. If he stays in his bed or watching TV all day, or if he's doing golf, of course it's not the same demand. The virulence of the bacteria, if you have a huge infection with general infection and septicemia, of course it's not the same treatment, and of course the treatment he had before. There's a lot of studies, multi-standard study. I'm going to go quite quickly to all the studies. All of them, in general, show a better success rate for a single stage and less complication. Infectious complication and non-infectious complication are more common in double stage than in single stage. But of course, no one in those studies and all those multi-center studies talk about which patient had the single stage and which patient had the double stage, because very often when we are very stressed about the aspect of the patient, the infection, there's pus everywhere, it goes between the muscle, it means it's a more severe case, and in those cases you're going to go to a double stage, and probably the outcome will be less good than the other patient. American multi-center study, the same. There was no reinfection, and there was better result with the single stage solution. Another meta-analysis show again reinfection rate is lower for the single stage than the double stage, and lower complication rate also, but the results in terms of outcome was about similar on those in this study. Joe, that's your study. So again, it's a small study but very well documented, and there's 17 infections treated, and as you can see, with 2 years follow-up, as you can see again, the one-stage solution gives good result, and the debridement, the soft tissue debridement, including debridement of the tartar cuff, doesn't change anything on the results. Many other studies, as you can see, always advocating for the single stage solution, which gives in all the studies, as you can see, evaluation single versus double stage. Everything seems to tell us that we should do a single stage surgery every time. Another one, as you can see, again, everybody is advocating for the first stage. You see again, primary outcome. So again, much better with a single stage. So what are we doing? What are you doing? We're going to see after this, but in all the studies that I've looked at, nothing, no one tells us about which patient had which surgery and why. The cohorts are not very homogeneous. So of course, if you look at the very bad patient, they will have not as good result as better patients. So at the end of the day, we use the chronicity as one of the most important factors, and also the patient characteristics. As I said here, the two-stage is favored by us, but all the articles are in favor of a one-stage solution. Antibiotic, many different procedures. We use 3 months after the surgery, but as you see in the literature, it's very, very variable from 10 days to 3 months. It's with an average of 6 weeks. It has to be, of course, pathogen specific. In France, we have to ask the advice of an infectious disease specialist, and also we have to ask the advice for some departments in Paris. By the way, JD, who is just gone, is working in one of them. There's 2 in Paris, so when we have an infection on orthopedic in general for a plate or shoulder, we have to ask an advice to those specific departments. We don't have to follow what they say, but they give an advice, and in case of suing, for example, it can be difficult to say that we did something else than what they advise us. So antibiotic therapy starting the day of the surgery, after the surgery, of course. We use spatial replacement. The one we use is filled with gentamicin, but there is some studies and there's no difference between different antibiotics. Some use vancomycin or Jour, as you can see, but there is really no difference. And usually the patient, when he's hospitalized, has IV antibiotic, and he have a Peros antibiotic afterwards for usual length of 3 months. Of course, when you ask the patient, you want one-stage procedure where you have one surgery and it's finished, or two-stage procedure where during 2 months you have 2 surgeries, and during 3 months you will have a very poor shoulder, they will advocate for this. But what we think is when you remove the stem, you can make a lot of bone damage, and we prefer to wait until the bone is better before doing the second stage. The stability of the new implant will depend on the quality of bone, and when you have a huge soft tissue infections going everywhere around the shoulder, it's quite difficult to put an implant inside the patient. I have 2 cases recently where the Ambroise Paré department told us to do a one stage, but I couldn't do it. There were so many pus everywhere. I removed a lot of muscle. It was impossible for me to do this. As an orthopedic surgeon, used to remove a foreign body when you have an infection. Of course, if the bacteria is a Staphylococcus aureus or Streptococcus, there is no way of leaving the implant. That's the theory of Philippe, because he advocates and we advocate for a 2-stage revision. It was a retrospective and comparative with a cohort. We used the prompts with SSV and the constant score. There was a control group, as you can see, which is very similar. As you can see, it was mostly Shoulder arthroplasty, osteoarthritis, and a few fractures. The germ was mostly the Cutibacterium again, with a few epidermitis, as in the literature. And as you can see in the result, it was quite comparable to the control group. So in fact, what we think is, even if it's a very bad news when you have an infection, it's a difficult surgery, there's a choice of single stage, 2-stage. At the end, the results are not so bad and are comparable to other groups. And also what we think when you do a 2-stage revision, the second stage is very easy. In fact, you have a very nice surface. It's very easy to remove the soft tissue and to put your implant. Salvage procedure, there is the resection, arthroplasty, or the implant. In the literature, there is no difference in terms of infectious eradication, but a major difference in terms of outcome. With this, that's one of my patients. You can see, I don't have a picture of the patient, but he has such a good motion, he doesn't want the second stage. So the functional outcome is much better with a permanent antibiotic spacer. So our way of treatment, less than 1 month, we just change the modular implants, and except when there is a massive soft tissue infection. More than 1 month, we do a 2-stage procedure. And when there is a massive bone loss, we cannot put another implant, the patient is too fragile, we don't do the second stage, and we keep the permanent antibiotic spacer. Antibiotics in our experience is for 3 months. Here at the American Hospital, we have to collaborate with an infectious disease specialist, and in France, as I told you, we have to ask an advice to the Werthel Center for Complex Musculoarticular Infection, GD being one of them. Of course, there's a lot of research to be done, because as I look at the article, we should do a prospective studies, because we don't know the cohort that are in the multi-center studies or in the meta-analysis. All patients are mixed up, and there's really a big work to do to make homogeneous cohorts. There could be some other adjuvant therapy that we don't know to eradicate the infection. We don't know how to isolate the factor that help the decision between 1 or 2 stage. And we don't know exactly, that's one of the most and the great areas, we don't know how this germ comes into the joint, because when you have six years after a surgery, an infection with this thing, without anything special in the patient, how come? How did it go inside the joint? Was it in the joint the day of the surgery, and there is symptoms just 6 years after the surgery? This we don't know, and probably that's one of the more important way to study and to make research. Pathogeny of the germ, as I told you, is it coming from the blood? Is it coming during the surgery? Is it coming from the scar when the nurse is changing the dressing? Is there communication between the axillary skin and the joint? Or is the bacteria present in the joint even before the surgery? It's a complex problem, as you know, you all done this with difficulty, but you know, if you do the right thing, usually there's a very big and nice rate of of eradication of the infection, and finally, the outcome are not so bad. The question is between 2 stage and 1 stage, and I'll let you, that's the articles. Thank you.
Okay, thank you. So next talk is about another complication that can be very tricky and difficult to treat, which is spinal and cranial fracture after reverse shoulder arthroplasty. Well, the frequency, when you look at the literature of this fracture, are about 10%, depending on the series, and most of them are insufficiency fracture. It's not traumatic fracture in most of the case, and usually this fracture occurs during the early post-op follow-up, between 3 and 6 months. As you can see, immediately it's less than six months. And this fracture leads to a major clinical impact with pain, loss, reduced loss of motion, and a high risk of non-union if you do not operate these patients. 2 classifications are used. The most widely used is the Levine classification that distinguishes 3 kinds of fracture. Type 1 is the fracture that involves the acromion. I'm sure that you can see that. So type 1, the lateral parts, least severe because they involve the anterior part and the medial part of the deltoid. And type 2 and 3, type 3 is the posterior part, so scapular spine fracture. And what is important about this classification is that the medial fracture for maybe 2 and 3 have the greater functional impact because it involves the posterior part of the deltoid. If it's fractured here, the posterior part of the deltoid won't function very well, and this fracture has a poor prognosis with a high risk of non-union. So what is the injury mechanism? The mechanism of the fracture is linked to the design of the reverse that medialize the center of rotation and lower the harm, that it will lead to stress on the acromion and on the spine. And as I said, these are primarily fatigue fracture, and most of the patients, they do not report any traumatic event. Okay, 2 categories of risk factor for this fracture. Patient-related fracture, it's fracture that are related to bone fragility, and fracture related to the prosthetic design. So the fracture related to the patient, most of them are fracture related to a bone fragility, so all patient osteoporosis, patient with inflammatory arthritis, especially this patient who have corticosteroid treatment, history of shoulder surgery, and for sure if you have a thin acromion, it's a little bit more fragile. The fracture linked to the implant is the patient where you use an excessive distalization, a huge humeral lateralization, and other patient when you put your superior screw on the direction of the spine, it can be a cause of a fracture of the spine. So this fracture have a major, as I've said, functional impact. Usually it's patient that were going quite well after the first surgery, and the patient come and say, I had sudden pain in my shoulder. Initially, I was able to lift my arm like this, and now I can't reach 90 degrees. Very painful. There is also a risk of instability if the fracture is highly displaced, and most of these fractures are displaced, and non-union is really frequent, especially as I said in type 2 and 3, so the medial fracture in the Levine classification. How to do the diagnosis? It can be tricky and it can be difficult to see the fracture on simple X-ray, and that's why in most of the time the diagnosis is a little bit delayed. It's a patient, so no fracture, it's an immediate post-op X-ray. Here the fracture that is occurred, but it's difficult to see. Here you can see it for sure. So standard radiograph is not very sensitive to diagnose the fracture, especially in the early stages. It's necessary most of the time to use a CT scan to clearly see where the fracture is. What are the treatment options? As usual, 2 kinds of treatment, non-op or operative treatment. So the indication for non-op treatment is the fracture that involves the acromion, so type 1 fracture, non-displaced fracture, or for fragile patients with limited functional demand. What are the modality of this non-operative treatment? Usually you put your patient in a sling, in a friction sling for 6 weeks. And in this patient, even when it's type 1 and not displaced, as you can see in the literature, you see that the union is achieved in around 2/3 of the case. In displaced fracture, in the opposite, it's 1/3 of the case that you can reach union. This patient had anyway a poor functional outcome with, as you can see, lower prompts and a very bad range of motion with an anterior forward elevation that usually do not reach 90 degrees. The other option is to do an open reduction. This is indicated in patients with a type 2 or 3 for medial fracture, for displaced fracture, patient in a chronic setting with a non-union of fracture, or for sure for patient using RSI instability. What are the modality of this treatment? Usually it's recommended to do a double plating. Sometimes there is a publication also about hook plates that come under the acromion. In a chronic setting, in case of non-union, it's recommended to use an allograft autograft, and for sure it's necessary in all cases to use a long plate that goes through the anterior length of the spine. What outcome? This is a publication of Bauer. I think it's this one, very interesting, that compare operative treatment versus non-op treatment. And the conclusion of the author is that early open reduction, it leads clearly to superior outcome, especially for the 2 or 3 fractures. You can see union in 93% of the case versus 30% in case of non-op treatment. Quite good range of motion and quite good prompts. But it comes with a high rate of complication linked to the harvesting of the graft if you do an allograft, or linked or go to the plate that can be, cause some problem under the skin. So at the conclusion, so the fractures are frequent. Most of the time, it takes a little time to diagnose of this fracture because you do not see them very well on the X-ray. They have a high impact on the patient these patients do not recover in most of the time completely. The key factor is the bone fragility, so be careful in patients with a risk of osteoporosis. In this patient, especially the patient who take corticosteroid treatment, take care to not put an implant that is with too much distalization or lateralization. Non-op treatment only for undisplaced fracture or type 1 fracture, and or if we should propose the patient early open reduction in the other case of type 2, type 3, or in case of displaced fracture. Thank you very much.
As we said earlier, there's more and more shoulder arthroplasty. Around, we don't have the real numbers, but probably it's going to be around 25 to 30,000 in 2024. 80 to 90% are reverse, except for Ryan, because it's 100% for you. There's an important increase rate, and the revision is about 1 to 2% of the cases. What's your cases, by the way, of revision? How many percent of your shoulder replacement are revision?
My own or?
Your own. You do 100 shoulder replacement, how many are revision?
Oh, how many
Each year?
revisions? Mine was up.
Not how many of revision of your arthroplasty, I mean in your schedule.
How
when
many
you
do
have
you do in 1 year?
in 1 year,
Revision?
how many revision in
What
1 year?
percentage of revision?
60 to 65 a year.
Revision? For how many not revision? Primary.
My revisions were 40 to 45% of my practice.
Oh, so yeah, it depends of your type of practice. People are referring patients to you, so it's different. Same thing for you? That's the problem of getting older. As older you get, as difficult the cases you have, and you want the opposite. You would like to rest and to retire and to be, It's a difficult surgery because the stem after the first 4 weeks is really usually tightly fixed, either by osseointegration or by cement. And of course the difficulty depends on the type of stem and the presence of or not of cement, and also of the necessity of removing the cement in case of infection or not removing it, and sometimes using cement under cement if you don't need to remove. The number of humerus fracture during arthroplasty revision is around 50%, 16% in every articles I've read. Usually during the stem removal, but sometimes during the cement removal, sometimes during the reduction of the last one I had was during the reduction of the shoulder, of the implant. And 8% needed revision afterwards. Risk factor, For the infection, it was male. Now it's female. Instability and previous hemiarthroplasty. But the good news, there's a lot of humerus fracture. But the good news is finally there's not much difference on the final outcome. So you know this very interesting article about prediction of difficulty of removing the stem by Gauchi and Franco, and they compared the preoperative assessment, preoperative images of the patient, including radiolucent line, presence of cement, length of the stem, type of stem, and then they did captures, pictures and video during the surgery to see how many, for example, how many times the hammer was hit. And also they looked at the implant after removing it to see how many impacts of the hammer there was. And then they find a correlation between some, it makes Joe laugh.
It's just a study that I would never do.
But it's interesting. I found it interesting to show. I find it's very funny. It's very funny. So you see, for example, they count the number of so that's a blur, and then they count the number of hit of the hammer. You will see there's a video in the room. So there's 8, 10, 12 hammer hit, and then that's now 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Doesn't it depend on all the other things you do?
Of course, but they found a statistic relationship between what they found on the X-ray and this. Also, you see the impact on the implant, the presence of cement around the implant. So they had a funny algorithm. It makes Joe laugh again. But I found it funny. The filling ratio, cement or not, radiolucent line, stem type, and then easy, moderate, hard. So it's a way they have to. He has to try to know in advance if it's going to be difficult or not. But let's say it always can be difficult. Usually, well, when you do a revision, I don't know how you do. Usually the approach is a little longer than the first incision. When there is infection, excision of the sinus, and I do very deep excision of the sinus until the bone. That's when you do the bacteriology test if it's an infection. Excision of the soft tissue. I don't know how far you go. Are you like cancer surgery, or do you just go to the normal soft tissue? Then saline or antiseptic or antibiotic cleansing. There's no study that compare the liquid you use to wash the joint, either in hip or in shoulder. Myself, I use only saline, but sometimes it's also religious to use betadine or antibiotic in powder or any powder. Now that the system are modular compared to before, to the knee arthroplasty and the first arthroplasty we have, which were sometimes much more difficult to remove. Now it's a modular system, so you can remove some of the pieces and then use special instrument provided by the company to remove the stem. It can be easy, especially for short stem or stemless, of course. It can be easy when there is a massive infection and loosening to the bone infection, but it's quite unusual. And it's a difficult step of the procedure. Probably it's the more difficult one. The reconstruction of the glenoid surface is the more difficult, but the removal of the stem is the more difficult on the humerus. And it can lead to important bone loss and fracture. And that's why we said earlier that we favor the two-step solution for infection, because we want to be sure that the bone is good to put a new implant and maybe have a longer outcome for the patient. Then comes the osteotomy of the humerus shaft. I do it with motorized saw, using saline irrigation to prevent the bone to be burnt, but I know that some are doing with the chisels. It's a very difficult and precise scaffold. You have to be really concentrated to this when you're doing it, and fracture of the shaft is not uncommon. We say it's about 15%. Preoperative assessment, it makes Joe laugh, but maybe it is possible to do a preoperative assessment. Anyway, when you look at the X-ray, you know it's going to be difficult sometime or not. Of course, it's more difficult on the right picture than the left one, which could be, of course, much easier. It depends on the length of the stem and the presence of cement. The osteotomy of the humeral shaft should be lateral to tendon insertions. The usual site of osteotomy is just next to the pectoralis major insertion. By the way, it could be elevated without any problem usually, and sometimes it is, quite usually it is elevated to be able to do the ostomy. The length depends on the stem of the presence of the cement. Usually, my boss Le Tournel, which I talked about earlier, used to make the line, the osteotomy line, round using a small blur or a small rongeur to prevent cracking from the major osteotomy line. And usually, I first start at the metaphyseal only, and very often, just by doing an osteotomy on the metaphyseal humerus, it is possible to remove it. Then comes this very dangerous rotational movement that we do, and it's very difficult to know exactly how far you can go when you grab the stem. You can do it and you don't break it, but it depends on the type of bone, on the age of the patient. But that's probably the better movement. Then you carefully, so you try to rotate the stem, and if not successful, then you have to go to the complete osteotomy, which could be either a window, which shouldn't be more than 5 millimeter, and or for some colleagues, just a distal window, which I don't do. I usually do if I cannot, I first do a osteotomy on the metaphyseal humerus. If it doesn't go, I go directly to the tip of the stem, and I do around 5 millimeter osteotomy. Okay. Then comes the time of the removal. So it's difficult to make a drawing on this, and I have no pictures. I'm sorry, but the chisel must be manipulated with a lot of caution. And usually, I use the scissors. I hit the cement on the stem. The dangerous thing is to put the chisel between the bone and the cement, because if you do this, very often the chisel is going to perforate the bone. Then I do when there is a fracture, some do plate. Some do plate. I never done it. I usually do a cerclage. Well, we used to do cerclage with metal. Now we do cerclage with a type of rotator cuff suture. It should be placed before osteotomy. And I've operated a guy who had a nerve injury and a vascular injury with this, so you have to be, of course, very careful and stay close to the bone. And sometimes you can use this. I don't know if you have this. We have this for hip, and we also can use it for. I don't use it myself. I never had the opportunity to use it, but it is also usable for the shoulder. It's the ultrasonic cement removal, and we have to use the same instrument that we use for the hip, the small chisels. That should be used again very carefully and never between the cement and the bone, because if you do this, you're going to perforate the bone. So the thing is to hit the cement directly with the chisels.
Stefan, and with this system, you have to be careful about
the nerve. Yeah, but it depends on the length of the tube. Yeah. But usually the radial nerve is much further, of course. That's why it's not used usually. That's why I don't use it. But some have used it. Thank you.
So my assigned topic is when and why do we use allograft proximal humerus for humeral bone loss? And obviously this is not the only option. If you have severe bone loss, you've got endoprosthesis, tumor prosthesis, other options. But Philippe wanted me to address using allograft bone. So this is classification. Probably the more simple of the ones that are out there, but practical in terms of, the first zone being the tuberosities. This becomes important in terms of getting lateralization, the greater tuberosity. So if you look at most of the current tumor prostheses, they have some kind of lateralization part of the prosthesis to get the deltoid wrap, and certainly that happens if you use an allograft, especially if you size it properly. And then zone 2 and 3 relate to, how long the stem is going to be. If you're using tumor prosthesis, how many segments you might need, or how long the allograft has to be. There are other issues that you have to think about in revision arthroplasty. It's the thickness of the bone, the amount of bone. Is it ectatic? Is it really thin? So sometimes you have bone up to here, but functionally you have only bone to here, because this bone is basically bone for insertion site of soft tissues. It's not structurally good, and sometimes in allograft, you just disregard that bone. You cut it, you put it back around the allograft so that you reattach some of the soft tissue insertion site, but the bone in zone 2 is so bad that really you're dealing with a zone 3 in terms of how much allograft you're going to decide to use. So what are your choices? You have endoprosthesis. This is a very old style endoprosthesis. This would not be something you might consider using now because of the not having the deltoid wrap effect on the proximal portion. You've got the topic of this conversation, which is use of an allograft. And then there's fusion. I've done probably 24 of these types of cases of glenohumeral fusion after failed arthroplasty. I've published, 3-4 papers of this topic. We're not going to cover that. Very difficult surgery. Sometimes you have to use vascularized fibula because the amount of bone loss is pretty severe. And then as a poor function, sometimes as a salvage, you're dealing with resection arthroplasty. There's still a role. I'm going to present one case where you might say, why didn't you do a resection arthroplasty? So this is an article that is now probably a historical classic article from Mark Frankel, and he looked at, the indications for the surgical technique and some of the biomechanics related to APC. Why do we do APC? Well, it's obviously very important for restoration of bone stock. That's probably the primary justification. Soft tissue reconstruction, if you get an allograft that has the attached soft tissues, you can attach the tissues that are left to the allograft soft tissue. That may help stability. It's mostly to try to restore bone. And sometimes that's valuable, particularly in a younger person, where you say, well, this may not be the last revision. If the bone graft incorporates, I get a stable prosthesis, maybe I have something easier than if I'm revising a all metal replacement. Very important, relevant to the stability of the stem. So if you have the proximal part of the stem well fixed in an allograft that is well fixed to the native bone, especially if it incorporates, then you have protection of rotational stability of the stem. And as I said earlier, maybe for revision. So this is a line art from Mark Frankel's work that shows, what the value is of putting allograft where you get this sort of better wraparound effect. If it's a tumor prosthesis or an endoprosthesis, a lot of these prosthetics now have that component built in, again, for the same reasons of trying to improve the stability of the component. This is some, again, work from Mark Frankel with relationship to some benchtop biomechanics, and he looked at 2 issues: the stability of the stem and torsional biomechanics with and without an APC, and the modular versus the non-modular prosthetic. This was the setup that he used for testing, and you can see pretty dramatically when there's a bone loss with a APC construct, you get better torsional stability, and then again the improvement with non-modular component versus a modular component. And again, this is some of this is still relevant, particularly related to APC. There's not too many modular components these days, but again, there are still some on the market. So what is the amount of bone? Typically, this was a rule that he put out, 5 centimeters. I think when you're in that ballpark, you might consider ordering something ahead of time. Again, having the soft tissue, so more of a soft tissue than just bone allograft alone. And then you can size it. Typically, if you have a ptatic bone where it's widened and the bone seems structural, you might choose to get a much smaller allograft so that you intussuscept or put one tube in the other tube. That helps the stability, it helps the bone incorporation, it helps you preserve some of the soft tissues that are attached to this ectatic bone. I'll show you a case of that. This was the original construct, a long sort of step cut. His concept was initially to have this and then cerclage, wire it for the stability, and obviously put a cemented stem so you'd get a combination of the stabilization from the long stem, the cement, and this cerclage. Since that point in time, you know, he's looked at plating and other kinds of concepts. There are other concepts with more distal fixation, non-cemented on the stem, and then plating the allograft with a longer stem prosthetic. So a lot of work has been done to try to improve the prosthetic design specifically for allograft use. Most people, at least in the United States, and I think in Europe and other countries, for different reasons, in some countries it's almost impossible to get an allograft. In the US, it's not impossible. You can get allograft pretty readily. The problem is it's hard. It's hard to get the rotation right, especially if you do a step cut. It's hard to get the soft tissue tension length right. So most people say, I'm going to spend another $5,000 or $10,000 and get metal prosthesis. It's faster, it's easier, and it's a practical choice. For those that say, I want to restore the bone material, that get bone incorporation, hopefully, and I want the soft tissues, then they continue to do allograft. So here's a case example. It's one of my patients from a long time ago. This looked like an infected shoulder. It was not an infected shoulder. This was metal allergy, probably the worst case of metal allergy I've ever seen. And that prosthesis was put in correctly. It was just spun around. And this is one where you can see the amount of bone loss. I kept this bone, but you'd say structurally, there's really not much useful bone there. This is really bone loss from here to there. But we got a smaller size graft. You can see I put it inside. You know, this much of it is inside the shaft. It was intentional. This was a pretty big guy. I got a pretty small sized graft. And between the intussusception, the cemented long stem, this worked out pretty well. This was his 4-month post-op. You can see this was Grammont style, so this is probably a case from, I don't know how many years ago, 15 plus, maybe longer. And this is his 2-year follow-up. He had actually an intact, you can see this actually incorporated. He died of unrelated causes, I think about 8 years after the surgery, and this stayed intact a long time. This is another patient. Again, this was a difficult case. Never was infected. That was the blessing. After this many surgeries, miraculously, this never got infected. And again, if you think about this, by the time you take all these screws out and plate, you know, you've got a tremendous amount of bone loss. This again was a Grammont style prosthetic. So this is a case that now I actually saw her about 2 or 3 years ago, and she was probably 10 years out and still doing well. And you can see that I kept the soft tissues. I used the soft tissues to reconstruct. I found her tuberosity. I put the tuberosity onto the bone. So that's something that you might not expect to heal. This particular patient, it did heal. And this is her 18-month follow-up. You can see pretty good early osteosynthesis. This is her 4-year follow-up. I don't know how she's doing now, but she did okay. You know, if you take out her extension of her spine and you set her upright, she's probably 60 degrees, but if you don't look too carefully, it looks like 90 degrees.
Hide the body.
Everybody who's well educated knows that's not 90 degrees, it's closer to 70 degrees. this is probably one of my most difficult cases in my career. So there's a lot of surgery before I got to see this patient. Had cuff tear arthropathy, got a reverse somewhere else. He had multiple surgeries. He eventually came in with infected shoulder. This is, again, not my two-stage revision. He came out, he had a spacer, got infected, lost all this bone. He came to me, this was me. This is when I got him. Sinus tract, draining, terrible soft tissue envelope, terrible. I advised this guy resection arthroplasty. He was well into his 70s. He was not a healthy guy. He was overweight. He had, I don't know how many surgeries before this, draining sinus, pus draining out. I said, listen, you know, enough is enough. Doctor, I want to keep my arm. And what that meant to him, he wasn't talking about amputation, he was talking about reconstruction. And I probably operated on him 4 times. You know, what had to happen was this. This was the critical element. So he had a latissimus flap to get the soft tissues to be viable enough to put in an implant. Up to that point in time, all it was one spacer after the other with no chance of this thing healing. So we got one of our vascular surgeons, plastic surgeon, to rotate a flap with skin. We waited, I don't know, 6 months, 5 months to get that to heal in. Then I went back in. This is what his pre-op was. So he basically had a useless, still had hand function, elbow function, so there was some reason to save the arm. And we ended up doing an APC on this guy. And again, this is his APC. You can see the step cut here. Again, intraoperative pictures. So here's his step cut. That's the hard part in APC. You know, you have to make that cut exactly in the right spot so that once you put the stem down, the arm is in the right rotation. That is not as easy as it sounds. And you could see even with trying to get the right tension, I think I ended up, no, I didn't have to use a spacer, but I used a thicker poly on this to get the right soft tissue tension. If I had to do it over, I would have used an APC with soft tissue. And this is his 2-year follow-up. He's probably now 10 years, maybe 12 years out. He was revised by one of my partners because he was done at surgery up in Cleveland. I was already moved to Florida. And he became unstable about 8 years after surgery. I think his soft tissues just kind of got stretched out enough. He was not dislocated, but a lot of recurrent subluxations. And they went back in and just put in a little metal spacer, made him a little tighter. He had a lot of poly wear also. So that's it. APCs fail for lots of reasons. Here's another guy, 14 surgeries before I got to see him. What's interesting about this case is look at the top 6 surgeries.
Yes, that's the strange one.
He had a minor problem. If any one of these 6 surgeries went well, I would have never seen him. But it was one, you know, they say every surgery was indicated, but the first one. You know, sometimes you get this sort of downward spiral at every surgery. So, you know, he had 2 reverses, he had 3 reverses, finally gets infected. His base plate, the screws were coming out the back of his shoulder. They weren't coming out, but you could palpate them. This was a Tom Norris case. So this is a guy from California that came to Cleveland. The the glenosphere was so inferiorly tilted, the screws were out the back. They didn't want to take it out, so they made a small incision, cut the screws. So I ended up keeping this glenosphere. This thing was probably in 30 degrees of inferior tilt.
But don't you think this guy also was pushing for surgery in the first steps?
I
Because
don't
I have
know.
one patient like this, been
No.
operated 6 times because he was always asking for a
this
new
guy
surgery.
was like normal.
So
And
who
he-
did 6 surgery for instability?
I don't know. So surgeon?
6 surgeons or 1 surgeon?
I don't think that was his person. I don't think he was smart enough to go to a different surgeon. That was probably his biggest mistake. But he wasn't the kind of person who actually wanted to have anything. I mean, he wanted to be like a normal person and just leave me alone or get rid of this problem. So this is when I took care of him, and I made some mistakes here. I mean, this was, I should have plated this thing from the beginning, but I didn't. I did a step cut. I thought the cement was going to be enough in the stem, but he went on to loosen negative culture, so this was not infected. But you can see this was, I gave up on APC at this point in time. You can see a loose stem. You can see the crazy position of it was anteverted and very far inferior tilt. The screws were literally coming out the back of the shoulder. So I ended up taking everything out. You can see how loose it was. The whole construct, cement, everything came out. So that was easy. That made it easy. And again, you can see this type of prosthetic has this sort of graded tuberosity detail. It has a combination of some porous ingrowth pads that go on the outside of the canal with the internal fixation from the inside. This guy was unstable at 5 weeks. I closed reduced him, put him in a brace for 3 months, and he was been stable ever since. And he's probably, again, 6 or 7 years out now from this. This is his 3-year post-op. So not a great result, but salvage, doesn't hurt.
He's young.
Oh yeah, this guy started when he was in his 20s. There's been a 30-year saga for this poor guy. So in summary, severe bone loss, more than 5 centimeters. Consider an APC if you're going to do it. I would order it with some soft tissue. I think you take off whatever soft tissue you don't need, but typically the capsule, the cuff around the proximal part, you find something to sew where that's left. Step cut, I think it's a good idea to add a plate. And you can, if you learn the rules, and again, the rules become rules that you learn by, trial and error and experience. You learn a little bit in a talk like this, but execution is from learning from doing. That's it.
So let's speak about the alternative center line. I intentionally put the name of Mark because rather than to put courtesy of Mark, I prefer to put Mark on the first slide. It is easier. So you can call that alternative center line because I discovered this word at the revision meeting with Mark. The other I would have called that to my fellow, I would have told that if you can have a good bite somewhere. This is what I think. Of course, it is an alternative center line, but sometime I will show you what I do. So sometimes you have to face severe bone loss, like that. We can say that it's a severe bone loss. And Jour told us that you can put bone or metal, or the third option is the alternative center line. This is a failure, and the idea is to find, if you have no bone loss, of course you can be there. If you have a posterior bone loss, you can be there, anterior bone loss. So you try to grab something and to have, at least during your surgery, something that you feel, not more, that is good enough to put a sphere on it. So you can plan it sometime, as you can see here. You can plan this alternative center line. I think it's a very good idea. Sometimes you have so much bone loss that it's, for me, it's only in the OR that you can really see what you are going to face. Hooded is the name for hooded sphere. Huh? This is the name for that. Huh?
Hooded.
Hooded. Huh?
Yeah,
You can.
hooded.
This is specific to this company, but if you want to still have, as Jour told us this morning, you can have this kind of asymmetric sphere in order to compensate the place of your base plate. If you are not like that, if you are like that, you want to have another. You want to have good base plate sphere everywhere. You have this hooded base plate.
For load sharing.
Load sharing. So this is a case of severe bone loss. This is the CT scan in 2D. This is the 3D reconstruction. You will agree it's a bone loss. Okay, I request a PSI. I was a bit upset during surgery because it didn't really help me during the surgery. I have several cases like that, but I just pick up one. And of course, you can discuss two stages. This patient is 88, and I think if you start to discuss with her with two stages, they don't want that. Not at all. It's not an option. So I remember this slide. I took this slide. So okay. So this is my PSI. Here is it. This is my PSI. Sometime we can. Of course, we have recorded this, but probably I'm not going to put it. In this small amount with surgeon, we can share this. Okay, for me it was not the PSI, it was just my finger. I'm going to show it to you. And this is what I do. In fact, I put my finger here. This is this case, huh? Not another case. I have a regular drill, 2.5, not more, or yes, 2.5. And I just try. And when I have
Good bone.
one centimeter with a good bite, I go there. This is the video. You see, it's very practical.
One question: the direction of the
I don't
drill
know.
is unusual, but the place of the drill, is it unusual also? It can be far from the center, for example.
Yes.
Any
Sometimes
place.
I put my
This is
finger.
where surgical navigation will make a big difference.
Yes.
Mm.
Yes. Because here you just say, you think, because you just see your glenoid like that, you say, oh, it's going to be there, and then after 2 millimeters, you're out. Okay, probably not here. You try another one, then another one, and sometimes you're like this, say, okay, good, I'm good. So that's what I did, that's what I do usually. And
You can't guess wrong too many times.
no, that's true, that's true. Let's say 3, maximum 4, I think. And this is the result, which is correct according to Jour. Probably,
That looks good.
no, that's correct.
The problem with this rule of my rule, it's not a rule, of where the lateral glenosphere should be, doesn't take into account tilt.
Mm.
It assumes that you have no tilt
Mm.
and you are 0 degrees. Because where the lateral glenosphere is relevant to soft tissue tensioning
Mm.
is very dependent on how much inferior tilt you have. Because the more inferior tilt, the more you distalize, you change it. So it's really saying if I put my base plate so there's no superior tilt, there's no, it's 0, I get 0, then your best lateralization is approximately the mid-acromion.
And I
Which
have,
came up in a previous case where there was, 20 degrees of inferior tilt, and they said, well, it's pretty far lateral. Some of it was because of the inferior tilt.
I have another one here. You see, it's
Yeah, that's another bad bone.
Yes.
Plus.
and
How many people do you use custom implants now for these cases, or do you still prefer
zero.
zero? Yeah.
I don't.
So is that a U.S. phenomenon?
No, I
There
don't think
seems
so.
to be a
Well,
growing number in the U.S.
I did this. You can see
I
that.
use a lot of wedge implants, posteriorly or upper, like this. I use Exactech, and there are quite a few, but then I never use also custom made, except for tumor and things like this. I mean, for
It's becoming a
osteoarthritis.
very common practice in the U.S.
Yes, but I think
But
that
it's expensive, and in France, the price is a problem.
Very expensive.
but it's another debate. I think for me, it would be very interesting to have a custom-made implant, not, of course, for the shape of the glenoid, just in order to know how much to lateralize, where I should end. But for me, the most important would be to have a very good three-point fixation, one in the base of the coracoid, one in the spine, and one in the pillar, which is for me the most important. I just don't mind to feel the difference. For me, the rebuild of the glenoid is just to know
Just to
where,
put the glenosphere.
just know where to end. But most of the time we think that we want to rebuild the shape, the primary shape, and we are very happy. But we have bad primary fixation of this, and it's a failure. That's what I think. It's a phase friend. If we can share, we can speak about that. But I think it's a phase friend because you rebuild this and you are very happy. But the most important is your primary fixation. Look at those two patients. They are now more than 5 years follow-up. They have only one fixation on the pillar, and it works. It works for those patients. I don't do a lot, and most of the time it's very, very low. You have the feeling that you are too low, but you are not that much, and it's a bit superior and posterior. We can discuss about that.
What did you do for this case?
I did that.
How long did that last?
3 years.
3 years. Pretty good.
And it was about one case. It's stupid to say that we have to do that. It's totally stupid. I know that. I teach that, so I'm not going to say that.
But it's an option you can take.
But it's a syringomyela. It's a syringomyela. The patient came to me. She had a shoulder like that, and she told me. I told her we can do nothing because it's a contraindication for reverse. And she said she has been in other center. Everybody says the same. And she came another time. She's 88. She was 88. And she said, "I prefer to die. Do something." I say, "Okay." I say,
You
"Okay."
should say, can I get that in writing?
Yeah.
Even if you do that, you are not protected. So
You can die even with the surgery.
I said, "Okay, here we go." And after 3 months, she came to the consultation, and there was a lot of fluid. And said, "Oh, blip, blip. Oh my God!" And after 1 year, it was okay. I don't know why. But I still believe that it's a contraindication for reverse, for NC.
From Mayo about syringomyela
And
reverse, and they did something like 30 or
30?
Yeah, and see it
We-
works.
This
It works?
is where Mayo?
Yeah, Mayo.
Yeah, I read the
Charge
same thing.
is the first project.
Talking about the burnt out syringomyelia. I don't understand it, but
perhaps there is.
I've operated on a couple of patients with syringomyelia and that had some pain. So they must have had some protection. I haven't done enough of them to know. You know, again, this is a comment I make in a room like this. I'm not sure I would make it if it was in a lecture hall with a microphone, but yeah, I think there may be enough variation in what syringomyelia really is that I just have trouble figuring out which ones you can get away with and which ones you can't.
The first person that I did that for, she had really bad Charcot shoulder, essentially sort of same appearance like that. Shoulders were the size of basketballs. She also had MS, and so she had really no function of her legs. And so I talked to her. She had a lot of pain, couldn't lift the arm up very well. And she was chronically dislocating. You could just see her in clinic just moving forward and back. So I talked to her about a fusion for the shoulder, and she said she couldn't. She didn't want to do it because she couldn't push herself up, and that wasn't easy either. So I gave her a reverse, and kind of like what you did there. And within the first 3 months, she fractured out the whole sphere and took out what a little bone loss she had left. So then I converted her to a hemi, and I did a anterior latissimus transfer with a lower trapezius transfer at the back, and it's been stable now for 2 years or so. She can lift the arm up, and she can push herself up with it. So
Interesting.
yeah, but you can see it kind of this way, but she puts it in the right spot. She can push herself up with it, and she can put her arm behind her back and stuff. So it's crazy. Those are challenging patients.
But most of the time, they are very kind.
Yeah.
Incredibly kind.
Yeah.
Those are the kind of cases you typically don't publish a series of.
Yeah.
N01.
I have another one. We can discuss about that. I have only one reverse after fusion.
That's a great one, yeah.
You have one? You have some?
I've never.
I've done only one.
No.
Why? That's
Yeah,
unusual.
interesting.
The patient was same patient than Joe. 15 surgery and probably 8 surgeries before, between 20 and 30 for instability. Then fusion at the age of 30, and I saw him. He was 34, and he said, "I'm incredibly painful. That tension everywhere." So, in fact, the most difficult for me was to make the decision, because I was not sure it was crazy or painful.
Yeah, there's a small, I had to present that topic in last year's Paris meeting. Valenti must have really thought I was being misbehaved, so he gave me this topic, fusion after failed arthroplasty and arthroplasty after fusion. And it was almost the last talk at the last day, and I said, arthroplasty after fusion. I have not done that. I don't know much about it, so I looked up the literature. There is a little bit written about it. Not enough to really provide more than about 2 slides in a talk. So you ought to consider writing up. One of them is just a case report, by the way. So, and this looks like this was an intra-articular fusion, not an intra-articular and extra-articular fusion.
I just look at the
Didn't
poster.
go from the humeral head to the acromion, just from the humerus to the glenoid.
That's a whole.
That probably makes a big.
And the fusion has been made by my former boss, so it was a bit more difficult. I don't have the. Anyway, I just want to show it to you because I cannot find the anyway.
Well, he has 0 degrees of abduction.
Yes.
Which is probably why his scapula hurts so much.
Yes, probably.
Not enough abduction.
Where did
Because
you get?
if you look at the spine, the scapular border of the scapula to the humerus, it's 0.
Yeah. But you're saying he has to work too much.
Yeah.
Oh, okay.
Yeah.
Because I've seen the opposite, where they crank it into abduction and then they get this tension on the neck and they try to put the arm down.
I don't know if I have the picture.
Plus, he looks like he's thin, a thin person. The best fusions I've ever done are people that are robust, have a large soft tissue envelope. either put their arm in more abduction and their arm is at rest with like 30 degrees of abduction, so they get way better function.
Just sits on their body. Yeah.
Problem is, if they take Ozempic after their fusion, they could have a bad result.
Just want to show you the. Anyway, I just during the surgery, I kept it. I kept this.
Would you just cut the plate?
Yes.
Nice.
Because I said, okay, it will probably prevent a spine fracture. So the plate is here. The plate is useful. I'm going to keep it. I don't know.
Is that where that plate went? Was on the spine of the scapula?
Sorry.
It looks like.
I can show.
Yeah, because you see on the wide view, it's in the superciliary process. There's not a whole lot of, I've never seen that, yeah.
Yes. Here it is.
Nice.
How did it turn out? What kind of result did you get?
Now I put him in a sling for 3 months. I put cerclage, cerclage on the glenoid side, like this for 3 months. No rehab, nothing. Now we're at 1 year. It's not painful anymore. No pain, zero pain. And he's doing this. And he's happy, so I am happy.
That's great.
So it is a pleasure for me to be here today with you. It's true, it's not the same topic, but I hope it will be interesting for you. I will talk about my orthopedic practice surgery in Senegal, about the difficulties and the challenges, and also I will introduce you our experience on the medical talent project, which is a project of the American hospital here in Senegal. So for this I will go through this plan. To understand why a project like this is important for us, you have to understand a little bit my history. So I first did a diploma of sports biology and medicine in Paris. After that, I did my residency in Senegal for orthopedic and trauma surgery. And after that, I know it's not common for you here, but I go a little bit in imaging. So I did a certificate in musculoskeletal ultrasound in Morocco. And after that, I do a knee arthroscopy certificate in Istanbul, in Turkey. So, you know, it is a very broad practice. I am not a specialist of only one joint. I have a broad practice in orthopedic and trauma surgery, both adult and children, both upper and lower limb. It is an obligation for us. My colleague here from Africa can confirm. We have to do a little bit of all. So I also do ultrasound guided and fluoroscopy guided injection. And when I first came to the clinic Bellevue, there was no orthopedic department. So I start to create it and developed the orthopedic department by doing emergency, by doing consultation schedules, and by doing operative planning with the team of the hospital. With the administration of the hospital, I designed and advised for equipment for the OR. And in Africa, it's not common to have a full technical equipment to do all surgeries. So hopefully we reach our goal. So we have fluoroscopy, orthopedic traction, arthroscopic tower, and we trained the local team because they never had done surgery, orthopedic surgery before. So we trained the nurse and the OR teams in new and modern orthopedic techniques. So this is to introduce our collaboration with American Hospital. So how it starts, the first contact was made by AHP International team in 2023 when they were in Senegal looking for a place for a local private hospital to start their project. There were a lot of meetings, discussion about all the aspects, especially administrative, nursing, and operational functioning. Then we had direct connection with AHP partner surgeon. So for the upper limb, it's Dr. Stéphane Romano, and for the lower limb, it is Dr. Eric Chirou. Then we have a first meeting with Stéphane in Dakar in May 2023, and we launched the project for the first mission. So how it works, we have a structured and biannual mission system. So we have 4 missions in total, 2 for the upper limb, 2 for the lower limb. And to do that, we have a pre-mission coordination at distance. First, I do the initial assessment of the patient in my office. And just to explain you, this project is not to do all type of surgery. What I can do, I do it by myself, but I am looking for patients needing surgeries that are not done usually in the country. So when I see the patient and, for example, he needs a shoulder replacement, then I have a staff meeting with Stéphane, with imaging, clinical information, pictures, to confirm the surgical indication. It is done by email, WhatsApp, and all these things. Then there is a full administrative and logistic preparation, which is not very easy, and hopefully AHP have a great team for that. And finally, if needed, not always, but if needed, if we need specific devices or specific implants, the AHP's international team contact the local laboratories, and they take with them all the equipment needed for this type of surgery in Senegal.
Imagine my suitcase.
Yes, a lot.
For shoulder
lot
replacement.
of luggage.
For shoulder replacement.
Okay, so there is a partnership with the industry, and because unfortunately in Africa, or probably in other undeveloped countries, we don't have access to all type of implants. When I look all these implants you use for shoulder replacement, it is not like that for us. We have a little bit of hip, knees, probably no shoulder, no elbow, so it is difficult. And for example, for the shoulder replacement, we have Exactech, and for the knee, we have United for the reconstruction knee replacement. All of this allows surgical assistance and skill transfer for medical, but also for the paramedical teams. We have on-site support from AHP EBOD's team, enabling hands-on training for our team. There is capacity building for the operating room nurses and technicians, and there is an improvement in our operating room organization, equipment maintenance, and sterilization process. To illustrate results of this project, this is some important key cases and milestones. So, for example, we have done with Stéphane the first shoulder arthroplasty in a private hospital in Senegal. It was in
2 years ago.
2 years ago, yes. Previously, it was performed only in one center, and it is a public center, but funded by Ordre de Malte. I don't know. It is.
It's an NGO called Order of Malte. It's the
Okay.
Knight of Malte. You know, it's a Christian organization.
Yes. In Senegal, we don't see a lot of patients who need shoulder replacement. I don't know why. Maybe it is related to. I don't know. The epidemiology is not the same. Maybe, I don't know. So for us, it was very important because this was a huge step in demystifying shoulder arthroplasty for us, because you know, when you don't know how to do something, it is always a pleasure to receive an expert, and quickly it makes you confident to maybe in the future start this surgery. Second case, we did the first elbow arthroplasty in Senegal. It was never done before. It was 6 months ago in a young woman with a rheumatoid elbow. It was a success, and we are very, very proud of this. And also, we start to do endoscopic carpal tunnel release, because usually we open it, okay? And because we don't have the equipment needed to do arthroscopic release. And there is an increasing demand from some patients, because you know, Google, ChatGPT, so they want to have the same healthcare than in Europe. And actually we are acquiring the equipment to do that. So, what are the technical gains through this program? Technical one, so we discovered new equipment. We acquired also new equipment through this program, like arthropump, smart release for the carpal tunnel syndrome, motorized burrs for arthroscopic acromioplasty. Maybe Stéphane later will tell you how we did the first shoulder arthroscopic acromioplasty without burrs. It was a little bit funny.
Like we used to do in the past.
We improved the operating room storage also and traceability. About the operational impact, it allows us to optimize the turnover between the patient. When Stéphane or Eric come to Senegal, there is a big motivation and involvement of the local teams, because we received the American hospital team, so we have to be very, very good, and it strengthens the operating room culture. But for the patient also, there is a high impact. Sometimes a patient needs a surgery which is not done in the country, so he needs to take a plane to go to another country. Sometimes there is a long administrative process to obtain all the papers. There is a high cost. There is a logistics, so it is difficult. And in American hospital, you know that because you receive a lot of patients from Africa or other countries. And today, with medical talent, we can perform locally quality surgery, advanced technique, with lower cost and easier access for the patient. So it is really a good thing. About the challenges and the resilience, they are competent physicians, but operating room staff are not formally trained for that. So they learn directly in the operating room in contact with the surgeon. There is limited biomedical maintenance capacity for the equipment, for the sets, for all. We have a limited access to some implants, so it is not so easy for us. Sometimes we don't have some drugs, some consumables, and it can be difficult also. And because of that, we are in a constant improvisation for maintaining safety, quality for the patient. As examples, in the first mission of Stefan, we had there was a patient who had surgery of the wrist in France with a French brand. Because Stefan was there, she wanted to remove the plate, and once we opened the
There was
wrist,
no screwdriver.
there was no the corresponding screwdriver. So
I've had that in the United States.
what
So
to do?
So I went to see the guy who is in charge of preparing everything in the OR or in the clinic. I said, can you show me your instruments? He opened his box. I said, can you sterilize this one, and this one? We did it, and one of them was working on the plate.
It was not screwdriver,
So we waited.
but Allen.
We waited until the sterilization with the patient like this.
How are you? Okay, and last time when we did the first arthroscopic release of CTS, it came with an optic, but which was not compatible with the camera. So we don't see. There is comment on dit de la buée? Fog. There is fog. So it was difficult, but hopefully
We did it.
we did it. So
Yeah, that's a funny thing.
that's a funny case. First mission, Stefan was around 8 or 9
I was in a restaurant. I
PM.
just ordered my meal.
in a very nice restaurant without me, and I received a call. A Belgian tourist was mauled by a lion during a safari.
It's not a joke. I thought it was a joke when you called me. I was at the restaurant, I ordered my meal and say, can you come? Someone has been eaten by a lion. I said, are you kidding? It happened often. Say, I've never seen this. He's from Africa.
Okay, so
That could only happen in New York City.
so a contact of these people knows that there was a French team in Clinic Bellevue. So they called directly, can you receive her? Yes, we can, okay. So she was transferred to Bellevue Clinic, and so firstly, surgical debridement in the middle of the night, but no possibility to do the exofixation because
It was not sterile.
no available and sterilized external fixator at this moment. So first, surgical debridement, and the next morning, exofixation. So you see, it was.
And I removed a few fingers also, as you can see.
If you go in a safari, don't
If you
try
count,
to.
there's one missing. One. Ah, you know how to count. By the way, David is the chief of the international team here.
So advice.
Good thing she had her nails done just before the lion.
Yeah, she had a nail,
Yeah.
just before.
Means that the lion has good taste.
It was a female. It was a female lion, as I heard.
Yeah.
It was a
exactly.
female lion, as I heard.
So after the exofixation, she was evacuated in Belgium to continue the care and have plastic surgery. And we have a follow-up with her. And actually, she was a nurse.
She's still a nurse.
She's still a nurse. She was right-handed, and actually, she's doing the care.
She had a flap. She had a flap,
like
and she's okay.
I don't know, Velociraptor or something like that. But it works. Okay. So advice for your next safari: don't try to take photo too close.
In fact, it was a car where there's a small place that you should take picture. But the woman, she put her hand out, and there was a lion on top of the car. She's been to this place, and the lion
When
tried
I've
to
been
take.
told this story by Stefan, I went to Senegal like a few months before this story, and I went to this place with my children, and we tried
to touch the lion.
You can touch the
you can touch the lion. You can touch the lion.
We did it. And after I saw this picture, I was horrified. I made my small kids touch the lion.
So that's what she did, but she touched the lion, you see?
Yes. So, what to think about this partnership? First, about the lack of hyper-specialization in West Africa. There is only few subspecialty training options locally, so we don't have hyper-specialized surgeon. There is a high need for very versatile surgeon, like all of us. We have limitations for equipment to do complex techniques, and there is an increasing demand from the patient for advanced orthopedic care. A very increasing demand. About the human impact, so we have built strong bonds between teams, mutual learnings, and exposure to a new perspective. The patient trust was reinforced by the presence of these international experts, and there is a pride and a motivation to elevate the level of the orthopedic practice in Senegal. About the value of training and academic exchanges, so there was acquisition of new surgical technique, new equipment, growth of paramedical competencies, and the academic integration illustrated by 2 days participation in this academic series for me. So we are very proud of this partnership, and how to launch the video? No.
The video. No, it's not working.
No. Je vais faire. Ouais.
Vas-y, je préfère que ce soit un pro. Dernière diapo et la vidéo.
Oui, d'accord.
Ça ne marche peut-être pas.
Ouais, peut-être pas.
C'est pas grave, t'as continué.
Ouais, ok, non, je sais pas. So, to conclude, it was just to share with you our experience and to say that these type of projects are very important, and if possible, we want to continue this partnership with American Hospital of Paris, and we are very proud of that, and that's it.
Okay, thanks a lot for invitation. Sorry, it's a big pity that I can't come because, you know, during the war it's a big problem to cross the border because you need to have special papers, etc., and it's finally it got me that I can't come to Paris.
It's okay, Basil. We forgive you.
Okay, thanks. And thank you for your support for us, Stefano, and for Ukraine, all the people, because it's really very, we need this very much, because without you, without France and Europe and US, we won't stand this terrible Russia. Thanks. So, Stefano, yes?
Yes, you can start.
Yes?
You can start.
So I would like to. Did you see our?
Yes, we saw the film. We saw the film.
Video?
We saw the film, so you can start by the presentation.
Yes, it's a film about our unbroken rehab center that we built when the war began to treat our not only soldiers but our civilian people too. So a little bit about this unbroken centers that we, from beginning of the war, we hosted over the 5 million of Ukrainians to Lviv. Our rehab center now the number that we receive, the 15,000 wounded people, is much bigger number this day, because it was about 2 years ago this quantity. So our rehab center, it consists of the surgery department, orthopedics department, psychological rehab, psychosocial rehab, physical rehabilitation, burn injury, bone implant printing, and prosthetic manufacturing. It's a slide of our orthopedics OR. In the surgery department, we do the reconstructive surgeries like full flaps, plastic operations, implantation, regenerative operations. In the burn injury department, our colleagues do reconstructive and plastic operations. They have a bank of skin, they do the skin transplantation. Prosthetic workshop, we manufacture and do to our soldiers the modern prosthesis for the Ukrainian soldiers. We already did the 12 bionic hand prosthesis to our soldiers. This is the picture of our physical rehab room. This is the picture of the psychological rehab. It's the mental health center and the psychiatric department. So the principle is that when we receive a wounded soldier, a multidisciplinary team is working with our patients. So it is the orthopedic surgeons, the surgeons, the psychological, the rehab man, and the psychiatrics. The building is the 7-story building, a big one, and now it is for 200 beds for the rehab patients. About our department, we are the orthopedic department. In our department, there are 110 beds, but almost today in our department is totally 160 patients. Most of them, near 100, it's a military guys. In our department, we perform all kinds of operations that we did before the war. It's the ORI with LCP and screws fixation, the intramedullary osteosynthesis, application of the external fixation. From the beginning of the war, we began to do much more debridement of the gunshot wounds, wax therapy, application of the soft tissue flaps, including the free flaps, the fibrillar flaps, the LD flaps, together with surgeons. We did the osteointegration with amputations. We began it in the 2023. We do the arthroscopy, the arthroplasty. Some maybe few clinical cases that we did. The first is the young guy that he got the mind blast injury, and in the end we did the high transfemoral amputation, and he had the broken forearm. We did to him the osteointegration of the femur together with colleagues from Australia, and we did the fixation of the fracture of the forearm. Now he is already returned to the normal social life. Another. Yes, this.
Next.
Sorry, maybe I'm a little bit quick.
No, it's okay.
He already returned.
Take your time, do what you want.
Another man, it is captain, the 57-year-old captain that had had a mind blast injury in the front line. At the end, we performed to him bilateral below knee amputations, and he has a fracture of the proximal tibia. We did the fixation of the fracture, and the patient said, if you will do bilateral osteointegration, I would say yes. We did, and hopefully he is okay, the wounds were okay, and he already returned to normal life. He is driving a car, he taking part in the para karate competition. Thanks God, he is okay. Another one is a 40-year-old man from east of Ukraine. He got the exploded grenade trauma in his kitchen, was delivered to the hospital. He underwent several operations: wound debridement, wax therapy, external fixation, local rotary flap, bone transport. We did to him the X-fix fixations, the debridement of the wound, and when the infection gone, we did the bone transport. It was last for several months, but at the end, his tibia got okay and healed. So please, next, yes, about this, sorry, this patient.
Continue.
We did the X-fix of the tibia, debridement of the wound, we healed the wound, and then we did the bone transport, and finally it's healed, and everything is okay this time. You can see the pictures of the X-ray. Okay, please, next one. Is the next one? No, we can put next one.
That's the shoulder.
It was one, the shoulder, yes, but it's the patient without the shoulder. He had a mind blast injury, and he just didn't have, after the trauma, his shoulder. And the question was what to do with this guy, yes? But I didn't know the future of this guy because he went abroad. Maybe someone did with his shoulder, maybe some 3D printed shoulder arthroplasty for him, I don't know. It was the time we had him in the hospital. His wrist was working, yes, but he had no shoulder. I'm sorry, it's not Stefano, do you hear me?
Yes, I do.
It's not that slide that I sent to Lauren.
Oh, it's okay.
He switched not that slides.
It's okay.
Can we switch another one, the latest one?
Yes.
This is a neurotization of the musculocutaneous nerve by one part of the ulnar nerve. It's the Oberlin procedure. I don't know if some of you have heard about this. We take part of the ulnar nerve, the one who is going to an extrinsic muscle, mostly the flexor carpi.
Yeah, so that slide, okay, thanks a lot.
Okay.
So, 8 missions of support with Dr. Stefano Romano. We first met Dr. Stefano Romano in 2022 during the medical mission he had in the front line, and then he went to Lviv, and we met him and his colleagues for first time. From the beginning, he actively joined our work with wounded soldiers and complex upper limb trauma cases. Since then, our cooperation has continued and strengthened. Dr. Romano has returned to Lviv 8 times. Each visit focused on treating difficult injuries, assisting in surgeries, and supporting the development of our upper extremity service. He has become a reliable colleague and true friend of our team. Next, please. Each mission lasted 5 days, during which Dr. Stefano Romano and our team conducted around 70 specialist consultations and performed approximately 20 surgical procedures. This mission consistently focused on complex upper limb trauma, reconstructive surgery, and advanced nerve repair techniques. Thanks to this regular collaboration, dozens of wounded soldiers received timely, high-quality surgical care and individualized treatment plans. Next, please. Through 8 missions of joint work, our team significantly strengthened its expertise in upper limb reconstruction. Together with Dr. Stefano Romano, we mastered a wide range of advanced surgical techniques, including tendon transfers for restoring lost function of the hand, wrist, elbow, and shoulder, nerve transfers, neurotization, including ulnar to musculocutaneous and other target motor nerve transfers from functional recovery after brachial plexus injuries, shoulder and elbow fusion procedures, including complex cases in severely injured patients. The latter procedure, along with the less invasive modification introduced by Dr. Romano, single screw coracoid fixation with soft tissue stabilization. Reconstructive surgery for high energy injuries, including coverage techniques, bone reconstruction strategies, and management of the combined soft tissue and nerve trauma. Advanced management of complex gunshot and blast injuries to the upper limb, modern approaches to postoperative rehabilitation planning, especially after nerve and tendon reconstruction. Next, please. During the last mission to our hospital, Dr. Stefano completed 47 specialized consultations, providing individualized treatment plans for each patient. Together with our surgical team, we also performed 14 complex upper limb operations, significantly contributing to the care of our wounded soldiers. Next, please. One of the most complex procedures performed during this mission was the brachial plexus neurotization in a patient who had a traffic accident and had completely lost of the ability to flex the elbow. During the surgery, the team Stefano identified the functional motor branch of the ulnar nerve and transferred it to the musculocutaneous nerve, which normally activates the biceps muscle. This nerve transfer is expected to restore elbow flexion function within the next several months as the new nerve fibers regenerate. Next, please. This was another mission when we completed the lateral procedure to the young football player. We did like the Stefano does with the one screw fixation. So the football player completely restored and returned to the professional footballing. Next, please. The surgery was successful. After 2 days in Flint, the patient began physiotherapy and fully returned to the sport what he was expected. This is the pictures for our children's hospital when we were there with Stefano and with the patient. Next, please. We sincerely thank to Dr. Stefano for his professionalism, dedication, and continuous support, as well as the organization La Chaîne de l'Espoir Foundation for enabling this valuable exchange of experience and for providing significant humanitarian assistance to our hospital. Thanks a lot.